atrophy or underdevelopment of the organs associated with the B cells. When we talk about condition which is given the name of CVID, it's again a problem of B cells. It's a B cell dysfunction. But the number of B cells are nearly normal, and it is not going to differentiate between males and females. Even though there is going to be a B cell dysfunction resulting in development of recurrent infections, but the important fact is that the areas in which B cells are present are actually going to be hyperplastic. So B cell defect, low concentration of antibodies, but when we talk about atrophy of the organs, we think in terms of Brutons. B cell problem, antibodies are less, recurrent infections, but when we talk about the hyperplasty of the organs like the lymphoid tissue, tonsils, appendix, right, we think in terms of CVID, common variable immunodeficiency disease. When we are talking about the most common example of a immunodeficiency disorder associated with immunoglobulin, that is to be remembered as IgA deficiency. Thankfully, for most of the patients, it is going to be asymptomatic, but it can have a very important presentation, severe allergy or anaphylaxis after blood transfusion. These patients obviously are at higher risk of development of allergic reactions like atopy or at autoimmune disorders, right? So because IgA is an example of a first line of defense against the mucosal antigens, so these patients are going to be having high risk of development of an issue, that is that they are going to be having high chance of respiratory and GI infections. Then all-time favorite of your examiners is DiGeorge syndrome associated with the acronym CASH22, cardiac defects, abnormal facial appearance, cleft palate is going to be seen in these patients. They will be having thymic hypoplasia and they would be having hypocalcemia. So classical terms that is to be remembered, patients are going to be having cleft palate, they would be having hypocalcemia and they would be having decrease in the size of the thymic gland. The problem is there is going to be a defect at the level of chromosome 22q11. That's a microdeletion. When we are talking about hyper-IgM syndrome associated with a problem in the interaction between, as we discussed, CD40 and CD40L. So only high concentration of IgM antibodies produced, IgG and IgA are going to be much low. When we talk about Job syndrome is going to be associated with hyper-IgE syndrome. So they patients are going to be having increase in IgE. They're also going to be having increase in eosinophils. And they are going to be having the presence of dental caries. They could be having the presence of a normal facial appearance, coarse facial appearance. They can be having the presence of a cold abscess. And they could be having the presence of high risk for development of allergies like eczema. When we are talking about Wiskott-Aldrich syndrome, the examiners love to ask you this as a clinical question, peripheral smear question, as well as direct question. These are the patients who are going to be having an X-linked recessive condition. So again, boys are more commonly affected. These patients are going to be having a triad. There would be repeated attacks of infections. There would be eczema, there would be thrombocytopenia. Another problem with the platelets is, one, the platelets are less in number. Second problem, the platelets are small in size, tiny platelets, right? And this is an example of a condition that is going to be seen because of involvement of the VASP protein. The VASP protein is going to be present on the short arm of chromosome X. So the clinical history that they talk about in the exam is that we had a patient who was having this classical triad. What is the next investigation that you have to look out for over here? So you have to do the VASP protein study, and that has to be done for the short arm of chromosome X. So this is what is going to be confirming the diagnosis of Wiskott-Aldrich syndrome. Whenever we are making a mention of something like SCID, that's a severe combined immunodeficiency. This is a condition in which, unfortunately, the patients are having involvement of both B as well as T cells. The condition can be X-linked recessive, in which there is going to be a problem at the level of the cytokine receptors. Interleukin-2 can be affected. There can be involvement of ZAP70. There can be JAK which is involved. But if we are talking about the condition in which there is going to be an autosomal variant, X-linked recessive variant, you were having interleukin problem. Autosomal recessive variant, which is one which is going to be seen because of enzyme deficiency, and that is adenosine deaminase deficiency. So that is what is going to be observed. So these patients are going to be having B and T cells which are going to be affected. So they will be having repeated attacks of infections. These patients are also going to be having a problem with T cells. So there is going to be an absence of the thymic shadow. And the patients are going to be having reduction of the T cell, which can be picked up or shown with the help of flow cytometry. So that's about the severe combined immunodeficiency disease. Adenosine deaminase deficiency is what was taken to be a target for taking care of with the help of gene therapy. So that's a historical significance that we just need to have an idea. We then talk about an example of a deposition of proteins extracellularly, and this protein is a fibrillary protein, non-branching fibrils. That protein is given the name of amyloidosis. Extracellular deposition of fibrillary protein, that's given the name of amyloidosis. The classification of amyloidosis can be generalized, localized, or it can be familial. When we are talking about generalized or systemic amyloidosis, This would be characterized by multiple examples. The first one is primary amyloidosis, which is very, very common. That can be seen because of plasma cell dyscrasias, like conditions like multiple myeloma or plasma cell dyscrasias. And what we have in these patients is that there is chemical nature of the amyloid, which is going to be AL. Why? Because there is formation of light chains in higher amounts. We have a condition that is going to be given the name of secondary or reactive amyloidosis, that is associated with secretion of cytokines, interleukin 1 and 6, quite commonly associated with chronic inflammatory conditions and sometimes in association with cancers, Hodgkin's and renal cell carcinoma. And that is going to be associated with the deposition or the nature of the amyloid protein as AA. A third example that we talk about over here is amyloidosis associated with hemodialysis. So these are the patients who are going to be suffering from a renal dysfunction. So they are having chronic kidney disease, because of which they are going to be having a higher concentration of beta-2 microglobulin. And this beta-2 microglobulin is what is going to be associated with the formation of amyloid. So most of these questions can be expected in the exam in the form of extended match questions or true-false based questions. That is what we need to have an idea. That's about generalized amyloidosis. Having a quick recap about the localized amyloidosis, the examples could include conditions like senile cerebral amyloidosis, that is associated with Alzheimer's. So the association is going to be with amyloid precursor protein that is going to be responsible for the formation of amyloid beta plaque. And this is going to be having the chemical nature of the amyloid as A beta. Second example that we can talk about over here is going to be medullary thyroid cancer. You would be having the cancer arising from the parafollicular cells, high formation or secretion of hormone like calcitonin. And this is what is going to be responsible for the chemical nature of amyloid as ACAM. Some patients who are going to be having diabetes, especially type 2 diabetes, can be having the involvement of amylin or islet associated pancreatic polypeptide. And this is what is going to get deposited as amyloid protein. We could be having a situation in which the patients can be having the presence of isolated atrial amyloidosis. This is attributed to the increased formation of ANF, that is atrial natriuretic peptide. And this can be responsible for causing a development of amyloidosis, that is AA. A for amyloid, A for ANF, that is atrial natriuretic factor. Clinical presentation could be cardiac arrhythmia or restrictive cardiomyopathy. We can be having a situation where the patient is going to be having the presence of prion disease, or that is spongiform encephalopathy. Remember the mad cow disease? The patients could be having the involvement of prion proteins, and therefore they could be having the presence of A prion P. We are then talking about cerebral amyloid angiopathy, in which the patients can be having a deposition of a special type of molecule called as cystatin C. And this can be responsible for having the amyloid nature as cis-C prefixed by A. So these are the examples of the conditions which are going to be localized amyloidosis. Hereditary amyloidosis, we just look at them. Familial Mediterranean fever, which is an example of a condition in which there is inflammation and therefore the liver is going to secrete a molecule called as pyrin. There is inflammation of the pleural surfaces, so pleuritis and serositis, and the chemical nature of the amyloid over here is going to be AA. Whenever we are talking about familial amyloidotic polyneuropathy, there is a mutant transthyretin protein, because of which the chemical nature of the amyloid over here is ATTR. Neuropathy, so obviously nerves will be affected. The question is not to be confused with a similar appearing question in the exam, which may ask you about senile systemic amyloidosis. Senile systemic amyloidosis is an example of a condition in which there is no mutation in transthyretin. It's a wild type of transthyretin, and this wild type of transthyretin is again going to be associated with the chemical nature of the amyloid being ATTR, and this is what is going to be associated with cardiac tissue involvement. So TTR, when it is normal, is associated with senile systemic amyloidosis, and TTR, when it is going to be abnormal, is associated with familial amyloidotic polyneuropathy. If we have a quick look at the organs affected in case of amyloidosis, of course, we can talk about the involvement of the cardiac tissue. That could be in the form of cardiomyopathy. Let us first have a look at kidneys. Kidneys are going to be affected in case of a lot of patients having amyloidosis. So one of the commonest organs affected. It is going to be associated with involvement of the mesangium, and clinical presentation therefore is in the form of nephrotic syndrome. And what is to be remembered over here is the renal venules are not going to be affected. The renal venules are not going to be affected. The moment we are thinking in terms of involvement of the cardiac tissue is going to be associated with more commonly patients who are going to be having primary amyloidosis. Clinically, it can be responsible for development of arrhythmia, and patients could also be having the presence of restrictive cardiomyopathy. Most of you have an idea, basic idea of medicine. When a patient is having restrictive cardiomyopathy, if you look at the ECG of these patients, they will be having the presence of a low voltage ECG. That's a hint that they give you in the question in the heart. Whenever we are going to be talking about amyloidosis, the practical significance is amyloidosis actually is the commonest cause of development of restrictive cardiomyopathy. So they may give you a picture of a cardiac biopsy tissue, and the cardiac biopsy tissue is going to be having a picture and a mention of the term low voltage ECG, and the image can also show you the presence of a pink colored material deposited extracellularly, which is suggestive of cardiac amyloidosis. When we think in terms of involvement of the liver is going to be increased in size, so there is hepatomegaly, and the first place in the liver where amyloid is deposited is space of Deci. Splenic involvement is again going to cause splenomegaly, but when you are going to be having the involvement of the red pulp of the spleen, this is going to be associated with lardaceous spleen. But when you get involvement of the white pulp of the spleen is going to be associated with a splenic appearance. It is going to be given the name of sago spleen, right? So as we discussed, red, which is called as lal in Hindi, lardaceous, that's a big fatty spleen. And when you're talking about white spleen, that is going to be associated with a millet-like appearance. So that's given the name of a sago spleen. Joint involvement can be seen in the form of knee joint involvement or wrist joint involvement. Wrist joint involvement is going to be responsible for causing carpal tunnel syndrome. Of course, that is known to you that the nerve entrapment which can take place over here is going to be affecting the median nerve. We can be having involvement of the skin as well, in which the patients can be having the presence of pinch purpura. The moment you pinch the skin of these patients, they are going to be having a fragile skin, so they can be having hemorrhagic spots. That is because of amyloid interferes with factor 10. And the second thing is around the eyes, there can be presence of hemorrhages which are going to be responsible for the term given as raccoon eyes. Skin involvement is also important because if there is amyloid deposition on the skin, this can be useful for the purpose of abdominal fat aspiration. One of the most common ways by which we make a diagnosis of amyloidosis, especially systemic amyloidosis nowadays. If we talk about the involvement of the GI tract, that can be in the form of development of increase in the size of tongue, macroglossia, nodular appearing tongue, and a protruding tongue. That's what you need to remember, macroglossia. And GI involvement is important because mucosa involvement of the oral tissue or the rectal tissue can be associated with the purpose of doing a biopsy, and that can be useful for making a diagnosis. What exactly is to be done for making a diagnosis is, once you've got a tissue, you can do the microscopic examination and you can be using the staining. If you are going to be using the staining, the commonest stain that is being used is Congo red. Under normal light, it is going to be showing you a pink red appearance, and under polarized light, it is going to be showing you an appearance which is given the name of apple green birefringence. So polarized light, apple green birefringence. Normal light, it is going to be showing you the presence of a pink red appearance. Amyloid is an example of a protein that is going to be PAS positive. It's also going to be having the presence of a secondary immunofluorescence when you're going to be using stains like thioflavin T and S. If we are going to be using the other techniques, say for example, you are going to be using something like electron microscopy, you would be having the presence of fibrils. These fibrils do not branch, so they would be example of non-branching fibrils. In case of special techniques like let us say crystallography or spectroscopy, you would be able to demonstrate the presence of beta plated structure. So these are usually the ones which are going to be asked in the exam, especially the Congo red and the staining, which is going to be example of important image-based questions. And this is what is to be remembered over here, that with respect to the normal light, it is going to be having the presence of a pink red appearance. With respect to the polarized light, it is going to be having the presence of an apple green birefringence. We of course can be using other stains like say for example specific immunostains or for the example scintigraphy, but these images are what are to be remembered from the perspective of the exams very, very importantly. Of course, no discussion of immune system can ever be complete unless and until we do make a mention of presence of autoantibodies. Autoantibodies, these are example of self-reactive antibodies which are going to be responsible for development of connective tissue disorders. When you talk about autoantibodies, they are going to be detected with the help of immunofluorescence. If we are talking about direct detection in the tissues, we are using direct immunofluorescence. And if we want to detect the autoantibodies which are present in the blood, then what we are using over here is the indirect immunofluorescence. Indirect immunofluorescence. The moment we wish to detect the presence of autoantibodies and the ones which are going to be associated with a better signal detection, I mean the amplification of the signal takes place, that's a basic rule. So we would be using the technique of indirect immunofluorescence. That was what was asked as a question. The other thing that we need to remember is that this is explained with us in detail in medicine, but some of the important examples of autoantibodies can include ANA. Right? It is a very sensitive antibody or sensitive test for making a diagnosis of a patient suffering from SLE. If you're talking about anti-dsDNA or anti-Smith antibody, anti-dsDNA or anti-Smith antibody. That is what is going to be very, very specific for making a diagnosis of SLE. We could be having a condition in which the patients are going to be having the presence of a condition that is given the name of CREST syndrome, calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. This would be associated with the presence of anti-centromeric antibody. When we are talking about the condition that is going to be given the name of systemic sclerosis, this is the one which is going to be associated with the presence of an antibody that is called as anti-topoisomerase antibody. A condition which is going to be testing the knowledge of ophthalmology, it is going to be testing the knowledge of ENT, it is going to be testing the knowledge of pathology. Sjogren's syndrome, dry eyes, dry mouth syndrome. This is the one which is going to be having the presence of antibodies, anti-Rho and anti-La antibodies. Antibody. Patients could be having a situation where they are going to be suffering from a condition like myositis. So we are talking about something in which the patients are going to be having dermatomyositis. They can be having the presence of an antibody that is given the name of anti-Jo1 antibody. Some patients are going to be having an overlap of manifestations, some SLE-like manifestation, some myositis-like manifestation, some sclerosis-like manifestation. That is what is going to be given the name of a mixed connective tissue disorder. This would be associated with the presence of an antibody that is given the name of anti-U1 RNP antibody. Anti-U1 ribonucleoprotein antibody. So, very basic fact with regards to the antibodies and the presence of some of them which may be helpful in doing an initial screening, and the confirmation subsequently has to be done. But repeating the point, that detection of autoantibodies is best going to be done with the help of something like the indirect immunofluorescence. That is what we just need to remember over here. So exam question these days can be based upon match the following with respect to the antibodies and the diseases, or that can be an example of a question where they ask you factual questions, or they can ask you certain image-based questions regarding this. So this is what is going to take care of our discussion now from the topic of immunity. Hi friends, in this video we are going to be having a discussion now about the important features pertaining to the topic of neoplasia. Now, before I share with you the important features associated with neoplasia, let us just quickly have a recap about certain important terms which are asked in the exam time and again. The first term that I would like you to be familiar with is a choristoma, which is a normal tissue which is going to be present at an ectopic site on an abnormal site. The second one, which has been asked in the exam more frequently with the increased, I would say, enthusiasm, has been hamartoma, which is in a presence of an abnormal tissue which is going to be present at a normal site. So at a normal anatomical site, you are having a disorganized tissue. Now, studies have shown, cytogenetic analysis shows that hamartomatous growths do contain the presence of certain types of chromosomal aberrations, and therefore they are going to be associated with the presence of increased risk of cancer. Usually, the questions asked in their exams, which we are going to be talking about subsequently, would be pertaining to hamartomatous polyps in the GI tract. If we talk about a term that you read in the questions, that is desmoplasia, there is too much of a fibroblastic response that you see around the tumor, which is because of the secretion of certain types of fibrogenic cytokines. Whenever we're going to be talking about a special example of a tumor that is given the name of a teratoma, what makes it so special is that it is going to be having its origin from more than one germ cell layer. And this is going to be primarily because of the fact that this is going to be associated with the origination from the totipotent cells. Now, the moment you think in terms of the origin from the totipotent cells, you will be reminded of the fact that the teratoma is commonly going to be seen in the gonads. And one of the important extragonadal sites of a teratoma happens to be in the mediastinal region. Teratoma, if it is present in the gonads, that means the testicular tissue, we simply call it as a testicular teratoma. But if it is present in the ovarian tissue, we call it by the name of a dermoid cyst. Very classical image-based question, which will show you the presence of a cut section of an ovary, which shows you the presence of skin, it shows you presence of adipose tissue, it shows you presence of cartilage, tooth, hair, right? So that is what is going to be associated with dermoid cyst or ovarian teratoma. Question regarding to the image-based question for hamartoma happens to be, one can be a polyp-based question, the microscopic appearance. Another one asked in the exam is the one which is having a radiological association or a finding popcorn calcification, which you associate typically with a pulmonary hamartoma. Of course, as and when we are going to be talking about the other important example of an important image, the one which we have talked about earlier as well, that is of a Reed-Sternberg cell. Now, let us have a look at the important features that you would associate with any kind of a neoplasia. So, features of neoplasia would include the classical 4 features, out of which if we talk about and make a reference to metaplasia, this is the most reliable feature of malignancy. most reliable feature of malignancy. Now, when we are talking about malignancy associated metastasis, most of the tumors are going to be malignant in nature and they will be showing you metastasis. But two important exceptions that I want you to remember. One, which is given the name of a glioma, and the second one that you need to keep in mind is a basal cell carcinoma. They are malignant in nature, but they do not show the presence of metastasis. Also, when we have a spread of the tumor, it can take place by multiple mechanisms. Say, for example, the lymphatic route. Say, for example, the vascular route. Say, for example, direct involvement of the cavities, out of which the peritoneal cavity happens to be the commonest cavity affected. Clinical importance would be lying in the fact that if there is a tumor which is malignant in nature and that is using the lymphatic route, we would have the concept of what is given the name of the sentinel lymph node biopsy. So this is something which is very much pertinent for cancers like, let's say, CA breast. So breast cancer, vulval cancer, malignant melanoma, and for a lot of other malignancies, we would use the concept of sentinel lymph node biopsy. The moment we are talking about the second property, that is going to be something like an invasion. And invasion is classically going to be seen as a feature of an invasive carcinoma, which practically means that there is going to be an infiltration and crossing over of the basement membrane. When we talk about the non-involvement of the basement membrane, we would be associating it with the term that is carcinoma in situ. So carcinoma in situ is going to be an example of a term which would be used when we do not have involvement of the basement membrane. A third important feature that we have in case of malignancies happens to be the rapid rate of growth. And this would be associated with the transformation of tumor, which is going to be having 10 raised to the power of 9 cells, just about 1 gram of a tumor, which can grow very rapidly to a massive tumor, which is having a weight of 1 kilogram as well at times. That would be having the presence of 10 raised to the power of 12 cells. The rapid rate of growth is facilitated by the presence of certain stimulators or certain facilitators, which are coming because of the presence of a phenomena, which is given the name of Warburg effect. So Warburg effect is a special situation, or it's a special term that we are using, in which even after the availability of sufficient amount of oxygen, the cancer cells utilize glucose by the process of only and only glycolysis. Now, once glycolysis takes place, obviously we'll be getting the formation of the pyruvic acid. This pyruvic acid is responsible for the formation of intermediates, and these intermediates are required for facilitating the replication rate of the tumor cells. So, in the availability of oxygen, tumor cells are utilizing glucose by glycolysis. So I can use the term aerobic glycolysis. And what is the reason or the importance of knowing about aerobic glycolysis? Importance number one, it is going to be responsible for the formation of intermediates required for faster cell replication. Fact number two, such cells, the tumor cells, when they have aerobic glycolysis, their requirement of glucose is going to increase massively. So this is what is going to be associated with the term that we read. It is going to be associated with glucose hunger. And diagnostically, this glucose hunger is utilized when we are performing an investigation like PET scan in case of patients having malignancy. So wherever in their body they are having the collection of the tumor cells, you would be having the presence of the 18-fluorodeoxyglucose, which is going to get accumulated at those sites. And that is something which can be picked up readily with the help of the PET scan. So glucose hunger is going to be useful for picking up the collection or set of tumor cells which are present anywhere in the body of an individual. That is going to be based upon the utilization of 18-fluorodeoxyglucose. When we are talking about anaplasia, it's an example of a microscopic change that we need to make a mention of. And this microscopic change is important because this microscopic change is going to be an irreversible change. And that is what is going to be considered as a hallmark feature for malignant transformation. So normally when you have cells which are being exposed to some kind of a, I would say, a bad stimulus or some kind of an etiological stimulus, they can have a stem cell reprogramming responsible for the development of metaplasia. If the injury causing agent is persisting, we can have dysplasia. So, and then we are going to be having a progression into a cancer. So cancers are characterized by high nuclear cytoplasmic ratio. Cells are going to be having a loss of polarity. There is going to be the presence of a high degree of pleomorphism. And when we have anaplasia, there would be a presence of abnormal mitotic figures as well. The problem that we have in anaplasia is that it is absolutely irreversible in nature. That means it's a kind of a no go back situation for the cell. The hallmarks that we associate with the presence of any kind of a malignancy happens to be, the first happens to be self-sufficiency. So when we talk about self-sufficiency, I are going to be talking about the role of special genes which are present in our normal cells, which are given the name of proto-oncogenes. Proto-oncogenes are physiological genes. Their function is to increase the rate of replication of cells. There are 5 types of proto-oncogenes that we need to have an idea about. That would be clear from this diagrammatic representation. And just having a quick recap of what you have seen in the main video section as well. We have the presence of a growth factor, It attaches itself with a growth factor receptor. It is responsible for secretion of signal transduction proteins. The signal transduction protein goes into the nucleus and results in the formation of nuclear transcription factors. And this is what is going to be responsible for causing activation of cyclins. So 5 important subtypes of proto-oncogenes that we normally have: growth factor receptor, signal transduction protein, nuclear transcription factor, and finally cyclins. If there is any mutation, remember, for every gene we are going to be having 2 copies. Even if there is a mutation in one gene, even if one proto-oncogene is going to get mutated, it is going to become overactive. What can be the reason for its overactivation? That can be because of a chromosomal translocation. That can be because of a promoter insertion. That can be because of increased activity of an enhancer. That can be because of amplification. So any of these 4 causes can be responsible for overactivity of the proto-oncogene. And if that happens, there is going to be increased proliferation of the cell. Proto-oncogenes, please remember, were physiological genes. But when they are going to become overactive after mutation, we use the term oncogenes, cancer-causing genes, oncogenes. And as you can understand, they can be of 5 types. So what we are asked in our exam is the 5 important categories of the proto-oncogenes, which if mutated can be giving rise to a cancer. And that is what we need to pay our attention to, because this is what they will ask you in the exam in the form of the gene-related question. So the current trend of the exams is that they would be giving you extended match questions, wherein you are going to be given the name of genes on one side, you are given the name of certain cancers on the other side, and you have to match them properly. Talking about the category, the first category of genes are going to be growth factors. That can include genes like PDGF, which is also going to be given the name of the cis gene, and this is going to be associated with development of a tumor, which is given the name of a glioma. Of course, we can be having the presence of hepatocyte growth factor, which is going to be responsible for causing a development of the hepatocellular carcinoma. More attention has to be paid from the exam's perspective for growth factor receptors. Very, very important with respect to the frequency with which they are being asked in the exams. When we are talking about epidermal growth factor, it is going to be of 2 types, ERB-B1, which is going to be associated with lung cancer in the patients. And we have a second one which is given the name of ERB-B2, which is also called by the name of HER2-neu. The moment people realize that we are having ERB-B2, also called as HER2-neu, they have a smile on their face, just as you are having, because most of us tend to remember HER2-neu or ERB-B2 would be associated with, yes, breast cancer. So ERB-B1 is associated with lung cancer, specifically adenocarcinoma of the lung, whereas ERB-B2 is going to be associated with breast cancer, right? When we are talking about the next one, this is going to be RET gene. RET gene is going to be associated in a patient who is going to be suffering from a syndrome that is given the name of MEN2 syndrome. MEN2 syndrome patients classically are going to be having medullary thyroid cancer. They also are at high risk for development of pheochromocytoma. In fact, you can remember and see from the table that you are also going to be having medullary thyroid cancer, which is going to be seen with higher frequency in these patients. We then have a gene which was asked in the INICT exam, which is about the ALK gene. And the moment we are talking about ALK gene, the first 2 alphabets will always help you remember the names. AL, adenocarcinoma of the lung, as well as anaplastic lymphoma. So 2 examples that are mandatory for you to have an idea. Adenocarcinoma of the lung as well as anaplastic lymphoma are going to be associated with ALK gene. We also having the presence of what is going to be given the name of neuroblastoma as well as inflammatory myofibroblastic tumor over here. Whenever we are going to be talking about KIT gene for some reason was asked in the exam more frequently. It is associated with the mesenchymal tumor of the stomach. That tumor is what I want you to remember. It is given the name of GIST tumor, mesenchymal tumor of the stomach. And it is also seen in case of a gonadal tumor, which is given the name of a seminoma. So KIT is associated with GIST tumor. It is also associated with seminoma. Having said that, we talk about the third category of the genes over here. The third category are example of signal transduction proteins, in which one of the most important genes that we need to remember over here is RAS gene. RAS gene, which is also going to be associated as an example of an important gene, especially at the examiners love to ask you time and again is with respect to KRAS gene. KRAS gene is what you see in a patient suffering from colon cancer. When we are talking about the other important gene, we need to have an idea about HRAS gene. HRAS gene would be associated with patients, elderly patients who are going to be having the presence of clinical presentation of hematuria. Now, when you think in terms of a cancer causing hematuria, 2 cancers immediately come to your mind. So, bladder cancer, urinary bladder cancer and kidney cancer. So, HRAS is associated with urinary bladder cancer as well as it can be associated with a patient who is going to be having a kidney cancer. NRAS for that matter is going to be associated in a patient who is going to be suffering from a melanoma. Now, what was asked again in the exam? BRAF gene mutation. BRAF gene mutation is what you see in a patient suffering from hairy cell leukemia, and it has got a very strong association. That means 100% of the patients having hairy cell leukemia are going to be having a BRAF gene mutation. May be associated at times with patients who are going to be having benign nevus, can be associated with melanoma as well. But this one is going to be very characteristic. That's what we need to have an idea over here. The other one, which is high in yield for the exams, apart from KRAS, apart from BRAF, is JAK-STAT. So JAK-STAT is what you're going to be associating in a patient who's going to be suffering from a myeloproliferative disorder. Multiple examples of myeloproliferative disorders are known to you. Essential thrombocytosis, thrombocythemia, polycythemia vera, chronic myeloid leukemia, polycythemia vera. So in general, it is a feature associated with myeloproliferative disorders. It is very, very characteristically associated with a tumor that is going to be given the name of polycythemia vera. So JAK-STAT associated with polycythemia vera, right? When we are talking about the nuclear transcription factor, that's a fourth category. The most important example of a nuclear transcription factor, which is to be remembered from the exams perspective, is going to be the MYC gene. Now, because it is most important, so the other way of making a mention of this is it is also called by the name of master regulator of cell proliferation. If you increase the nuclear transcription activity, of course, the rate of replication of the cell is going to increase. So logically, that would be an example of a master regulator of cell proliferation. The commonest example that is asked in the exam is that of c-MYC, which is associated with a tumor which is given the name of Burkitt's lymphoma. We do have an association of something like n-MYC and a patient who's going to be having neuroblastoma. And we are familiar with the fact the patients who are going to be having L-MYC are going to be having the lung cancer. Specifically, patients are going to be having the small cell lung cancer. So 4 categories of genes of proto-oncogene type that we talked about over here: growth factors, growth factor receptors, as you can find, signal transduction proteins, and nuclear transcription factor. The more the name of the cancers associated with individual genes that you remember, friends, the better it is for you any day. Talking about now the 5th category, that was cyclins. Now, cyclins are example of proteins which are going to be appearing off and on. They appear intermittently. So, they appear cyclically. Whenever they appear, they activate certain enzymes which are called as kinases. So, these enzymes are called as CDKs, cyclin-dependent kinases. We are aware from our knowledge of the different phases of cell cycle that a cell which is present in a resting phase is called to be present in a quiescent phase. Then it is stimulated to enter into the replicative phase where it is going to be entering into the G1 phase, then S phase, G2 phase, and then M phase. So what is going to be pushing the cell from a resting phase into the active phase? That is going to be cyclins. The first cyclin, therefore, which is going to be involved, and that is what I would like you to highlight over here, is cyclin D. Other cyclins are also involved for the full replication process. So first thing that you need to remember is what is the sequence in which cyclins are going to appear. Cyclins do not follow English language, so it is not like A, B, D, E. The sequence is, as we remember with the acronym, the great batsman who helped us win in all formats of the game. Of course, Mr. Kapil Dev and Rohit Sharma have been added to the list now. But Mahendra Singh Dhoni personally remains all-time favorite. So, Dhoni ek akela batsman, right? So, D, E, A and B, that is the sequence in which the cyclins are going to be appearing. When they appear, they will be responsible for causing activation of respective kinases. So, cyclin D activates CDK4 and 6. Cyclin E activates CDK2, which is also activated by cyclin A, and then cyclin AB is going to be responsible for causing activation of CDK1. So write the name of the cyclins in the order: Dhoni ek akela batsman, right? And then the name of the CDK is 4-6. He used to use wonderful helicopter shot and 4s and 6s. Then running between the wickets, double runs, 2 times 2, and then 1. So this is what you need to remember so far as the relationship between cyclins and CDKs are concerned. Imagine a situation in which there is some mutation in the cyclins. So they are expressed more frequently or in more quantity. What will happen to the rate of replication of a cell? That is going to increase. And we do have legitimate example of a lot of cancers nowadays which we are aware of, which are caused because of overactivity of cyclin. One important example that I would like to share with you over here, friends, is that of mantle cell lymphoma. Mantle cell lymphoma. So mantle cell lymphoma is an example of a non-Hodgkin's lymphoma. And what we find in this kind of a cancer is that there is an overactivity or overexpression of something like cyclin D, right? That's what we need to remember over here. We then are going to be talking about the second category of genes after proto-oncogenes. The second category of genes about which you need to have an idea is the one which are going to be associated with the term tumor suppressor genes. Tumor suppressor genes are example of genes which are responsible for causing differentiation of the cell. They in fact control the rate of replication of a cell. They're also responsible for having a function that they're associated with DNA repair. They control the mitogenic activity. They inhibit too much of angiogenesis. Overall, the function is to be remembered: proper differentiation of the cell so that replication of the cell takes place in a controlled fashion. Now, as is the case of proto-oncogenes, we have got 2 copies of the tumor suppressor genes as well, because they are controlling the activity of the replication. So I can tell you that they are acting just like a brake of a car. So you do not speed too much, you do not kill yourself with overspeeding. When we are going to be having mutation of one gene, one brake fails in the car, as we shared in the main video as well. If one brake fails in the car, you still have a backup of a second brake. But if both the brakes fail, then chances of accident obviously are going to be there. Same story over here. Chances of cancer will be there when both the genes which belong to the tumor suppressor genes category do not function properly. And that's why you are going to be associating it with the term. That's what is given the name of a double hit hypothesis. So proto-oncogenes, even if one gene is mutated, chances of cancer is going to increase. But in case of tumor suppressor genes, both the genes have to be altered or mutated. Only then the chance of cancer is going to be there. And this was first discovered by a gentleman in association with the RB gene or the retinoblastoma gene. And the name of the person, as most of us are familiar, is called as Mr. Knudsen. So Knudson's double hit hypothesis first explained in association with RB gene, right? When we are talking about the different genes, they are going to be having different functions. So as per the classification, we may just remember the fact that RB gene, which is also given the name of governor of cell replication, RB gene, which is also being given the name of governor of cell replication. It's a controller or governor of cell replication, right? Very, very important gene for replication of the cell. That is what is going to be there. And then we have the role of P53 gene that we have already made a mention of earlier, which was responsible for initiation of apoptosis, right? We then are going to be talking about the role that is being played by the genes, which are very, very important in case of cancer of the breast tissue in case of males and females. That is the BRCA1 and 2 genes. So BRCA1 and 2 genes, why are they important? Because normal genes have a function. They perform the process or function of DNA repair. If these genes are going to become altered, if they become mutated, then the DNA repair does not take place properly. If DNA repair does not take place properly, we will be having cells with mutated DNA, altered DNA. So obviously the risk of cancer is going to be more. It's easily and obviously logical for you to recall that BRCA1 gene mutation is going to be associated with familial breast cancer. And these ladies are always at high risk of suffering from ovarian cancer as well. BRCA2 gene is associated with male breast cancer. And it is going to be associated with high risk for development of other cancers, including prostate cancer. Another gene which is to be remembered with DNA repair is the genes which are going to be associated with the terms like MLH and MSH. So they are the genes which are going to be associated with the repair. If they do not function properly, then there is presence of what we read as microsatellite instability, right? When we are talking about other genes, we need to remind ourselves of APC genes. APC genes is what you associate with a condition that is given the name of familial adenomatous polyposis. So normally they control the mitotic activity, but if they are mutated, then mitosis becomes too much. So polyp formation takes place, familial adenomatous polyposis. We can also have other genes, including the gene which is going to be something like the neurofibromatosis 1 and 2 gene. We can be having a gene that is given the name of the P10 gene associated with endometrial cancer, thyroid cancer in the patients. We can talk about PTCH gene, which is going to be associated with Gorlin syndrome. And remember the dermatological association, high risk of basal cell carcinoma. And we can be talking about SMAD genes, which are associated with presence of increased chances of GI polyps. So important examples that we just need to keep in mind with respect to each of these genes. Whenever we are talking about genes, which are genes, example include VHL gene. They are responsible for control of the blood vessel formation, or they inhibit angiogenesis. So when they get altered, too much of angiogenesis, if there is too much of angiogenesis, proliferation becomes easier. And that is what is going to result in spread of the cancer. Similarly, SDHB, that is succinate dehydrogenase gene, again an example of a gene that you need to remember. The succinate dehydrogenase also involved in a patient who is going to be suffering from GIST tumor, right? Also associated with pheochromocytoma. And we are having a gene that is associated with polyformation, STK11, serine threonine kinase 11. So when we are going to be talking about each of these subsequently, that's a time or that's a statement that is going to be given to you in the exam. And they would be making a mention of the particular gene and the particular cancer. That is what is to be remembered by. Then making a mention of the genes which are going to facilitate invasion. That's going to be given the name of CDH1 gene. CDH1 gene is what is associated with 2 types of cancers. Familial gastric carcinoma. And it is also associated with lobular breast cancer. So CDH, the cadherin is present between the adjacent cells. If it is mutated, the attachment is lost. And the cells separate out, so more chances of invasion, more chances of metastasis. That is what we need to remember so far as the tumor suppressor gene concept over here is concerned. Then there are certain other properties of the tumor cells about which we just need to have a quick review. For example, Warburg effect, which I already described with you. And this is what is going to be associated with the term aerobic glycolysis. and associated with the formation of certain types of intermediates which are required for tumor cell replication. We need to be familiar with an example of a chemical which is going to be called by the name of an oncometabolite that is produced because of activity of an enzyme called as isocitrate dehydrogenase. This may be involved in the development of certain types of brain tumors, and the oncometabolite, the cancer causing metabolite, is given the name of 2-hydroxyglutarate. Having a word then about the cells which are going to be having a limitless rate of replication, that is because of immortality of the cells, which we discussed during a discussion of Hayflick's limit. So Hayflick's limit concept, 60 to 70 times a cell can divide. But if there is going to be reactivation of telomerase, the cells are going to divide indefinitely. So that's going to be associated with the term immortality of the cancer cell. Having then a word about the process by which cells evade apoptosis, they inhibit apoptosis by overexpression of BCL2, as we discussed in case of a patient having follicular lymphoma. In fact, when you give anti-cancer drugs, tumor cells are supposed to die. But sometimes tumor cells will be very, smart, or they are going to be having an overexpression of a gene that is given the name of MCL1. And that MCL1 is going to be responsible for causing a development of chemotherapy resistance. Then making a mention of sustained angiogenesis. Sustained angiogenesis is going to be associated with the new vessel formation that is facilitated by the vascular endothelial growth factor or the basic fibroblast growth factor. And if we know this, if we inhibit these factors, we can inhibit angiogenesis. So we have got anti-cancer drugs which are angiogenesis inhibitors. Say for example, bevacizumab. Say for example, we have a drug like thalidomide, which are examples of angiogenesis inhibitors. Invasion and metastasis, what I just now explained, this is going to be associated with loss of E cadherin. And finally, tumor cells have a very smart mechanism by which they try to evade, they try to save themselves from the immune cells. That is going to be by what is given the name of immune checkpoint inhibition. Right? So we are having drugs which are going to be the chimeric antigen receptor T cell therapy now available, in which we are going to take care of these immune checkpoints. So these are new class of drugs which I believe have been discussed with you in pharmacology as well. The immune checkpoint inhibitor drugs, about which we need to have an idea. Say for example, tisagenlecleucel. I mean, the name is a bit tedious, but then it's an example of an immune checkpoint inhibitor drug, right? Talking then about a specific mention of certain types of defects in the DNA repair. So we are going to be having different types of enzymes which may be involved. Say for example, nucleotide excision repair defects is going to be seen as a feature of the increased risk of xeroderma pigmentosum. We could be having a situation in which patients are going to be having the presence of a mismatch repair that can be responsible for causing the development of hereditary non-polyposis colorectal carcinoma syndrome. We could be having a situation in which the patients are going to be having recombination repair defects. Say for example, Bloom syndrome. Or we can be having ataxia telangiectasia, or we can be having a condition given the name of Fanconi's anemia. Now, if you see the name carefully, what I want you to remember is the first condition, that is xeroderma pigmentosum, and these three conditions, the Bloom syndrome, ataxia, and Fanconi's, they are examples of autosomal recessive. I do believe you would be able to recall the acronym that we discussed, big facts. Bloom's, Fanconi's, ataxia, xeroderma, they're all examples of autosomal recessive conditions. Whereas when we are talking about the hereditary non-polyposis colorectal carcinoma syndrome, this is an example of an autosomal dominant condition. It is an example of an autosomal dominant condition. Now we are going to be having separate set of genes which are required for the DNA repair, whether it is a single stranded repair or whether it is an example of a double stranded repair. Say for example, if you are thinking in terms of something like the ATM gene or the BRCA gene, they are examples of double stranded repair genes. But when we are going to be talking about a gene that is given the name of MSH gene, then this is responsible for causing a repair of the single stranded breaks, right? So that is what was asked to you as an INA question as well. So that table becomes important. Then we are going to be talking about certain terms which are specifically associated with certain types of cancers. First one is oncogene addiction. Tumor cells in a patient suffering from CML are absolutely addicted to the tyrosine kinase activity. Why do we have tyrosine kinase activity? Because of Philadelphia chromosome. So if we inhibit this tyrosine kinase activity, the tumor cells are not going to be able to survive. And that's what you do with the administration of a drug like imatinib. So oncogene addiction is a term that you associate with a cancer, chronic myeloid leukemia, right? Talking about the second one, which is going to be chromothripsis, that means chromosome shattering. Shattering of the chromosomes is going to be seen in case of brain tumors and bone tumors. Chromosome gets shattered, brain and bone tumors are going to be at higher risk of prevalence in these patients. When we are talking about the third mechanism, this is differentiation therapy. So if we talk about tumor cells, they are undifferentiated or they are poorly differentiated. Suppose you give them some factor from outside which can induce differentiation, which can induce maturation. So the tumor is likely to be treated. That's exactly what is happening in a cancer which is given the name of acute promyelocytic leukemia. So it is treated with the help of something as simple as all trans-retinoic acid. So trans-retinoic acid or vitamin A is an example of a differentiation therapy inducing drug over there, and that is what is going to be useful for treatment of a patient having acute promyelocytic leukemia. Then there are certain types of changes which are going to be important, which are being given the name of epigenetic changes. Epigenetic changes can take place by two mechanisms that you need to remember. One is DNA methylation, and the second mechanism that we need to remember over here is histone deacetylation. DNA methylation and histone deacetylation, they are the important terms that we just need to remember so far as the questions are concerned in the exam. Now, what can be the reasons for development of a cancer? Three important reasons: exposure to chemicals, microorganisms, and radiation exposure. So we need to have an idea about different types of cancers and the specific chemicals which are going to be associated with them. When we are talking about the chemicals, the potential of a chemical to cause a cancer is something that can be tested with the help of a test, microbiological test, that is given the name of Amy's test. If I want to check whether a chemical can cause cancer or not, I can perform a test that is called as Amy's test, right? So that's what is important for you to remember. And the different types of cancers we can just rush through. Smoking is going to be associated with intake of polycyclic aromatic hydrocarbons, and that can be associated with multiple cancers, including GI cancers, including lung cancer, and pretty important for being the risk factor for development of bladder cancer as well as kidney cancer. Of course, cervical cancer is also going to be there. When we're talking about alcohol intake is going to be associated with development of oral cancer, esophageal cancer, and obviously easy one for us to remember, it's going to be associated with liver cancer as well. The moment we're thinking in terms of a cancer that is given the name of angiosarcoma, very rare cancer, but as we talked about, tap your brain, there comes the answer. So tap your brain, TANP, T for throat rust, which is an example of a radio contrast material, A for arsenic, which is going to be seen in case of the alloy factories or metallurgies, and we are talking about P, that is plastic factories containing polyvinyl chloride. So angiosarcoma is going to be associated with throat rust exposure, associated with arsenic exposure, associated with the polyvinyl chloride exposure. We are going to be having at times intake of a particular type of a toxin that is going to be given the name of aflatoxin. Aflatoxin is going to be seen because of exposure to a fungus that's given the name of Aspergillus flavus, and this fungus is going to be responsible for causing development of hepatocellular carcinoma. Why this fungus causes hepatocellular carcinoma? Because it is responsible for induction of P53 gene mutation, and there's a specific area in the P53 gene where the mutation is going to take place, that is the 249th codon. So P53 becomes dysfunctional, high risk of development of cancer. What is going to be the reason for the intake of aflatoxin? That is because the person has consumed contaminated peanuts. Fungus infected peanuts have been consumed by the person, and that is what is going to contribute to development of the liver cancer. If you are talking about exposure to a chemical like asbestos, so asbestos is something that is useful for insulation industry, whether we are talking about fireproofing, waterproofing, construction factory, car factory, shipbuilding factory, that's going to be associated with development of laryngeal cancers, ovarian cancers, and the kidney cancer as well. With respect to the thoracic cancers or the lung cancers, it is going to be very commonly responsible for causing bronchogenic carcinoma. Bronchogenic carcinoma is the commonest cancer seen because of this, but it is not going to be answered by you in the exam if the question in the exam talks about a specific cancer associated with asbestos. Specific cancer associated with asbestos is to be answered as mesothelioma. So when you write mesothelioma, MNS, most specific type of lung cancer because of asbestos exposure is mesothelioma. As and when we are making a mention of the nitrites, they can be present in the smoked food. So might as well be reminding you of certain types of parties and celebrations, and they can also be present in groundwater when it is contaminated. It is definitely increasing the risk of development of GI tract cancer. Any type of exposure to occupational dust can be responsible for causing lung cancer. If you are talking about an exposure to something like aniline dyes are going to be responsible for, examples would include something like beta-naphthylamine, and that is responsible for causing a high risk of development of urinary bladder cancer. Whenever we are talking about exposure to cadmium, it can result in prostate cancer. Benzene exposure is responsible for causing higher risk for development of leukemia. And of course, we understand our link with pharmacology. Anti-cancer drugs themselves are having carcinogenic potential. So if a person has been administered anti-cancer drugs, they are at high risk for development of a cancer. And that type of a cancer typically is an example of a secondary leukemia. Sometimes anti-cancer drugs can also be responsible for causing bladder cancer as well. So the summary is, you need to remember the cancer and you need to remember the particular chemical that is going to be associated with it. Having said that, the second component or the second reason for development of a cancer can be because of microorganisms. When we talk about aflatoxin, that's what we discussed, Aspergillus flavus containing peanuts, and there is going to be a mutation in the P53 responsible for causing liver cancer. H. pylori can also be responsible for causing two types of cancers. One is gastric cancer and the second is small tumor. We then talk about schistosomiasis, which was asked as a question in the exam, screening exam. Schistosomiasis is associated with urinary bladder cancer. Then we were asked a question in the NEET, as you can remember, Clonorchis sinensis associated with the development of biliary duct cancer. That's going to be cholangiocarcinoma. Hepatitis B, notorious DNA virus, which is responsible for causing liver cancer, primarily because of a carcinogenic protein, that is HBx protein, and can be responsible for causing chronic inflammation, because of which there is going to be a trouble, and it can also result in development of mutation at the level of the DNA. Whenever we are making a reference to something like HTLV is responsible for the development of a cancer that is given the name of adult T-cell leukemia. And the peculiarity of this kind of a cancer, it's a cancer that is going to be arising from the helper T-cell or the CD4 T-cell. Standard viruses are going to be important for the exam. They are very, very commonly asked in the exam. They are notorious as well. Epstein-Barr virus, it's responsible for causing high risk of development of Hodgkin's lymphoma. High risk of development of non-Hodgkin's lymphoma can also result in development of Burkitt's lymphoma as well as nasopharyngeal carcinoma. In the GI tract, Epstein-Barr virus has an association of causing gastric adenocarcinoma as well. When we talk about human herpes virus 8, most of us tend to remember about Kaposi sarcoma, because human herpes virus 8 was also called earlier by the name of Kaposi sarcoma herpes virus. What we tend to forget in the exam is what I want you to remember over here. It can be associated with the malignancy that is called as primary effusion lymphoma. Primary effusion lymphoma, and is associated with the development of multicentric Castleman's disease. Primary effusion lymphoma and multicentric Castleman disease. Whenever we are talking about human papilloma virus, of course, something which is of a lot of concern, especially in case of females, it can be associated with low risk subtypes. Low risk subtypes are responsible for causing warts as well as laryngeal papilloma. The high risk subtypes 16, 18, 31, 33, they are the ones causing cervical cancer, anal cancer, oropharyngeal cancer with higher frequency. Why that takes place is because this virus is responsible for secretion of certain types of proteins. Remember E6 and E7. The E6 protein causes underactivity of P53. The E7 protein causes underactivity of RB. P53, RB, both are examples of the controllers. They are example of tumor suppressors. So if you inhibit them, that means you are putting a failure of the brake mechanism. So that's why there is going to be a high risk of development of cancer. Then making a mention of hepatitis C virus that is going to contribute to the development of liver cancer. Right? So those are the important examples of some of the important microorganisms which are responsible for having an association with different types of cancers. Having said that, we just talk about the radiation exposure. Of course, ionizing radiation is going to be much worse, and this is going to be associated with high risk of development of blood cancers as well as papillary thyroid cancer. That's why in diagnostic radiology, you are going to be using a protective mechanism in the form of the radiologist, especially the intervention radiologist, wearing a lead apron. Non-ionizing radiation is not absolutely safe, especially when we are talking about exposure to something like UVB rays. They are going to be responsible for causing increased risk of development of skin cancers, and the risk becomes all the more when there is going to be a problem at the level of repair genes. So when there is a problem at the level of the nucleotide excision repair genes, patients are going to be having a condition that is given the name of xeroderma pigmentosum. Xeroderma pigmentosum. How exactly do we make a diagnosis of a cancer? Of course, that would be requiring the histological and the cytological methods, primarily the bread and butter of a pathologist. That would be something like an aspiration. That can be something like a biopsy. We do have a novel concept appearing nowadays, which is the concept of liquid biopsy. Liquid biopsy simply means that you take the blood sample in case of an individual, and in this blood sample that you are taking, you can be finding the presence of the circulating cancer cells. You can be having the presence of DNA material which is coming from the cancer cells, and you can be having the presence of certain types of special molecules which are given the name of exosomes. So once you have taken the sample, you process it further with the help of the techniques, like maybe you are going to be using the polymerase chain reaction, you are going to be using the presence of cytogenetics. you are going to be extracting the DNA which is present in case of the cancer cell, and you are able to detect it. That's how you're going to be making a diagnosis. Advantage of liquid biopsy is it is a very easy to perform procedure. It can be repeatedly done without causing too much of a trauma, whether it is financial trauma or whether it is a physical trauma to the patient, right? So it is something which is likely to be the future for making a diagnosis for the malignancies, right? We just talk about exfoliative cytology, wherein you understand the concept of something like the screening stuff that you do with a cytobrush and the air spatula, that is pap smear. So you use the exfoliated cells or the cells which have been taken out, examine them microscopically and identify whether they are of normal subtype or whether they are of the cancerous subtype. When we talk about IHC, that's going to be one of the key areas where the questions exams are going to be made. So identification of certain types of cancers. For example, if you find keratin, then this is what is going to be useful for making a diagnosis of a carcinoma. The moment we think in terms of a muscle origin tumor, that is going to be having desmin. Whenever we are going to be talking about mesenchymal tumors, they would be having the presence of vimentin. And if you're going to be having the presence of the glial fibrillary acidic protein, it is going to be associated with the glial tumor. So depending upon the type of intermediate filament, you're going to be having an idea about the kind of cancer which a patient is going to be having. Whenever we're going to be making a mention of something like flow cytometry, of course, that is going to be useful for making a detection of the CD molecules. How do we represent flow cytometry? The graphs, as you may have seen, the scatter plot, or you're going to be having the presence of what is given the name of the histogram and dots. Which CD molecule is expressed by a particular cell is exactly what is going to be useful for making the diagnosis of a specific type of a cancer, right? That's something that we talk in detail in discussion with hematology. Whenever we're going to be talking about now the newer methods which are being more relied upon, the molecular methods or the cytogenetic analysis methods, say for example, the polymerase chain reaction, say for example, the FISH technique, the fluorescent in situ hybridization. So they are going to be responsible for having a better and a more specific kind of a detection rate. Sometimes what we are going to be having is a situation when the patients are going to be having a adenocarcinoma in which we do not know what exactly is the primary. So that is what is given the name of carcinoma of unknown primary. In such a situation, we are going to be using two types of markers which are giving us some idea about the source of a primary. And these markers include cytokeratin 7 and cytokeratin 20. Depending upon the different permutations and combinations, we can be having certain cancers in which both of them are positive. We can be having certain cancers in which only one marker is positive. We can be having a cancer in which both of them are going to be negative. So more the ones that we remember, the better it is. However, the one which has been asked in the exam earlier was having a question, having a discussion wherein we were having the expression of CK20. It was not having the presence of CK7. And this is going to be seen as a feature of a cancer which is going to be given the name of colorectal carcinoma. Another cancer which can be having a similar finding can be a cancer which is associated with polyomavirus infection. That's a Merkel cell carcinoma. So colorectal carcinoma and Merkel cell carcinoma associated with expression of CK20, but they are not having CK7. So easy for us to remember if we think in terms of a chief manager or if we think in terms of a chief minister. So chief minister is working hard, working for 20 days. They are available for 20 days, but they take a 7-day break. For 1 week, they take a break, and this is what is going to be helping us remember that we are dealing with a cancer like a colorectal cancer or we are dealing with a cancer like a Merkel cell carcinoma. The other ones are the ones which are optional for you to remember, but primarily if you can just understand with respect to something like the cancers which are going to be CK7, so 7 plus and CK20 negative, there are 7 types of cancers. Not so lucky 7 over here as we can think in terms of the cancers which are going to be seen in case of a female. Say for example, the breast cancer, say for example, the endometrial cancer, say for example, the cervical cancer, right? So cancers in female, that's one. Then lung cancer. Then we are having the presence of something like a thyroid cancer. We are having the presence of salivary gland cancer. We are having the presence of pancreatic and cholangiocarcinoma, right? Making then a reference to what is going to be the special marker profile, which is going to be useful for making a diagnosis of cancers. And these are more important with respect to the questions that are likely to be asked in an exam with respect to a tertiary care institute. So when you're talking about something like a breast cancer, going to be detected with the help of either ER, estrogen receptor, gross cystic disease fibrous protein, HER2/neu was always known to us, and mammaglobin. Important ones that I would like you to remember in the order of priority are going to be that of lung adenocarcinoma. Lung adenocarcinoma is going to be picked up with the help of a marker that is going to be thyroid transcription factor 1. I want you to remember about a marker that is given the name of napsin A. I want you to remember about a marker that is given the name of SPA1, that is surfactant protein A1. The other example of lung cancers which can be asked in the exam apart from adenocarcinoma can be the lung cancer having a neuroendocrine origin. Neuroendocrine origin is going to be seen in case of which type of lung cancer? In case you can revise, that would be seen as a feature of small cell lung cancer. And this would be having the presence of markers like chromogranin, synaptophysin and CD56. What was a smart thing that we encountered in one of the exams recently? That they asked us a marker which is associated with a neuroendocrine tumor. But the question asked us specifically that they wanted to know about an intranuclear marker. Intranuclear marker which is useful for picking up a neuroendocrine tumor. These markers that we are talking about are not nuclear. They are either present on membrane or they are present in the cytoplasm. So the intranuclear marker that we are having for identification of a neuroendocrine tumor happens to be INSM1. INSM1 simply refers to insulinoma associated protein. So insulinoma associated protein is a novel marker. It's a new marker. Insulinoma associated protein is a newer marker for neuroendocrine tumor, but it is having a special property. It is intranuclear. So from the name itself, you can remember it. Intranuclear special marker for neuroendocrine tumor. That's not the right name, but that's the easiest way to remember this hack. Intranuclear special marker by which you can make a diagnosis of neuroendocrine tumor happens to be INSM. A third example of a lung cancer which I would like you to be familiar with over here is what is going to be given the name of a squamous cell carcinoma written right at the last. This is going to be associated as a carcinoma. So it will be having keratin. It is also going to be having positivity for P63 and P40. P63 and P40. So that's what we need to remember over here. So these are the three highlighted, blue colored highlighted ones, which are the different types of lung cancers. Beyond that, I want you to be having an idea if you possibly can. We can be talking about a marker that is going to be seen in case of germ cell cancer. So when we are talking about germ cell tumors, we divide them into seminomatous and non-seminomatous tumors. When we are talking about a non-seminomatous tumor, which is a choriocarcinoma, it will be having beta HCG. And we are going to be also having a role that is going to be played by AFP. Then when we are talking about seminomatous tumors, this is what was asked in the exam. OCT34, c-KIT and PLAP are markers for seminomatous germ cell tumors, right? Whenever we are making a mention of something like prostate cancer, of course, we are having the standard marker PSA, prostate specific antigen. And we are also going to be having a role that is going to be played by NKX31. NKX31, right? Of course, Love and Bailey would also make a mention and Robbins will also make a mention of Amaker. So, but the important ones, I will still prefer PSA, NKX31. If you are thinking in terms of a tumor, that's going to be a tumor that is going to be a hepatocellular carcinoma. Hepatocellular carcinoma is going to be having the presence of arginase 1 as a marker. Another marker that we need to be familiar with over here is HepPAR1. Next in the order of importance, mesothelioma. Mesothelioma is going to be having markers which are going to be calretinin, WT1, D240. Of course, mesothelin is going to be a giveaway. Mesothelioma having mesothelin, I mean, we don't expect that to be asked in the exam in case the examiners unless happen to be too kind to us. But these are the special example of markers about which we need to have an idea, which are going to be useful for making a diagnosis of cancers, right? Having said that, just a quick recap about the different types of tumor markers about which we need to have an idea over here. And when we talk about the tumor markers, the first one is beta HCG, which I already described with you, which is also going to be associated with the cancer that is going to be given the name of choriocarcinoma. Calcitonin is going to be seen in case of medullary thyroid cancer, also in association with Mentu syndrome. Whenever we are talking about catecholamines, so catecholamines are going to be associated with something like the tumors neuroblastoma and pheochromocytoma. 5-HIA, which some of you may remember, was asked to you as a screening exam question. This is seen in a patient who is going to be suffering from carcinoid tumor. Of course, we can be talking about something like the oncofetal antigens, carcinoembryonic antigen, very important, more important for colon cancer, less important for pancreatic cancer. AFP, which can be seen in case of benign conditions like hepatitis, can be seen in case of pregnancy, can be seen in case of, the GI development disorder, say for example, omphalocele, can be seen in case of a patient having liver cancer, even the gonadal tumors for that matter, the non-seminomatous tumors. So that is also important. But primarily, I mean, with respect to the histories or the questions which have been given in the exam, these are the two important ones which we need to remember. Then we are talking about prostate specific antigen, which is seen, of course, in prostate cancer and multiple myeloma patients who are going to be having immunoglobulins, right? Out of the mucin glycoproteins, most of the questions asked in the exam are from CA125, that is for ovarian cancer. CA15-3 is what you are going to be associating with breast cancer. Then we may have a marker like CA19-9 and CA27-29, which is more characteristically associated with pancreatic cancer. Having a word about the enzymes, we can be talking about enzymes which are going to be examples of enzymes like LDH, LDH will be associated with, remember, lymphoma, remember, dysgerminoma, and remember the Haddiwala tumor, as I told you earlier, it is going to be seen as a feature of a patient who is going to be suffering from Ewing sarcoma. As and when we are making a mention of neuron-specific enolase and chromogranin seen in neuroblastoma as well as small cell cancer. S100 is a marker that is seen in case of melanoma. Of course, that can also be seen in a patient who is going to be having a schwannoma. Might as well be seen in a patient suffering from Langerhans cell histiocytosis. Beta 2 microglobulin is what you are going to be seeing in a patient who is going to be suffering from multiple myeloma. That's what we need to remember. And a characteristic one relating our knowledge of path with orthopedics, Ewing sarcoma having a specific marker called as CD99, which was earlier called as MIC2. When we are making a mention of mamma print, of course, mammary gland is involved, breast cancer. ALK is what we discuss. AL, adenocarcinoma of lung. We discuss AL is for adult lymphoma as well. It is a T-cell lymphoma. And you need to remember the third example, that is a myofibroblastic tumor. Right? Inflammatory myofibroblastic tumor. So these are the important examples of certain types of tumor markers which have been asked in our exams, about which you need to have an idea. Winding up our discussion by making a quick reference to the paraneoplastic syndromes, in which hypercalcemia is the commonest paraneoplastic syndrome, which is most commonly associated with squamous cell carcinoma of the lung. It may be associated with breast cancer, kidney cancer patients also. However, the commonest one remains the squamous cell carcinoma that is associated with lung. When we are talking about Cushing syndrome can also be seen in a patient having lung cancer. But which type of lung cancer? It could be seen in a patient suffering from small cell lung cancer. Cushing syndrome can also be seen in case of the tumor arising, which is going to be like from the enterochromaffin cells like the carcinoid tumor. Whenever we are going to be making a reference to SIADH, that is going to be seen as a feature of small cell cancer, lung cancer. Hypoglycemia can be seen as a finding in case of a patient having sarcomas like fibrosarcoma. At times, it can also be seen as a finding of a patient suffering from liver cancer, hepatocellular carcinoma as well. When we are talking about polycythemia is going to be associated with a patient suffering from liver cancer, can be seen in a patient who is going to be suffering from kidney cancer, can be seen in a patient who is going to be suffering from a tumor that is given the name of leiomyoma, and is associated with the adrenal gland tumor like pheochromocytoma as well as hemangioblastoma. So some of them would actually remind you of a syndrome that we have mentioned elsewhere as well, that we talked about in the main video section as well, the VHL syndrome. VHL syndrome patients have renal cell carcinoma. They are going to be having hemangioblastoma. They would be having the presence of pheochromocytoma, and each of them individually can be related with the presence of a common paraneoplastic syndrome, that is polycythemia. Then making a mention of something like Trostu sign, which is the name that is being given to migratory thrombophlebitis. That would be seen in case of tumors which are going to secrete mucin. That can include something like acute promyelocytic leukemia, and including cancers like the pancreatic cancer as well as colonic cancer. Anemia and hypogammaglobulinemia, very, very pertinent, can be seen as a feature of a cancer that is going to be given the name of thymoma. Thymoma, in fact, can also be associated with a situation wherein the patients are having selectively the involvement of the red cells only without any involvement of WBCs and platelets. So if there is a selective involvement of the red cells, that's given the name of a pure red cell aplasia. That's what is going to be associated with thymoma. Whenever we are making a mention of acanthosis nigricans, thick and darkly pigmented skin, can be associated with a patient who is going to be suffering from stomach cancer, and may be associated with a patient who is going to be suffering from a lung cancer as well. Then dermatomyositis can be seen as a finding of breast cancer. Sign of lesser Trallat, in which the patients are going to be having an association with something like the stomach cancer. With respect to neuromuscular junction issues, patient can be having a weakness. Now, if this is a post-junctional problem, that is myasthenia gravis. So myasthenia gravis can be associated with thymoma. But if you are talking about a problem in which there is Lambert-Eaton syndrome, antibody formation against the presynaptic calcium channels, then this is a feature of small cell cancer of the lung. Uncommon ones which have been asked in the exam earlier can be related with something like opsoclonus myoclonus, which can be seen as a feature of neuroblastoma. We had a question asked in the exam in which the question was talking about an elderly patient who was having the presence of a testicular lymphoma, and then he had a development of a cerebellar ataxia. Elderly patient having a testicular lymphoma having the presence of a cerebellar ataxia can be attributed to the patient having which type of lymphoma? That will be an example of a non-Hodgkin's lymphoma. classically DLBCL. So even that can be an example of a paraneoplastic syndrome presentation. We can then talk about a condition that is given the name of limbic encephalitis. Limbic encephalitis can be seen in a patient suffering from small cell lung cancer. And finally, if I'm talking about subacute cerebellar degeneration, can be seen in a patient either suffering from Hodgkin's lymphoma, or at times it can be seen in a patient who's going to be suffering from breast cancer. So as the thumb rule, we understand that some of them are more important than others, but I mean, the trend is that extended match questions are going to be given to you in the exam, and therefore, the more that you remember, it will be easier for you to take care of such questions for the exam. So that is what is going to take care of a discussion of the topic of neoplasia. Hi, so now we're going to be having a discussion of one of the very important topics that is asked in the exams regularly, and that's the topic of hematology. We'll start off with a discussion initially of the red blood cell disorders, and then have a discussion about the white blood cell disorders and the platelets. When we are talking about the examination of the bone marrow, this can be done with the help of a technique that is given the name of bone marrow aspiration. For bone marrow aspiration, we can be using two types of needles. One which is given the name of Sahla's needle. Sahla's needle, which is going to be having the presence of a side screw. Or we may be going in for the examination that is with the help of Klemar's needle, which is having the presence of a skeleton and guard. Suppose the patient is going to be having a pathology because of which he is going to be having the presence of a fibrosis in the marrow. Or for that matter, he is having the presence of the conditions like hairy cell leukemia. Sometimes patients can have acute megakaryocytic leukemia. The aspiration is not going to give you any result, friends. So that's a condition that is given the name of a dry tap. In case that is a situation, we may have to go in for a procedure that is given the name of bone marrow biopsy. And these are the examples of the bone marrow biopsy needles. We also have heard of the names of needles like the Jamshedi needle as well. Please remember that if an individual is having the presence of reduced platelet count, that is thrombocytopenia, performance of a bone marrow examination is not a contraindication. Having said that, what are the preferred sites for performance of the bone marrow examination? In case of an adult individual, the preferred site happens to be something like the posterior superior iliac spine. However, in case the individual happens to be really obese, in an overweight individual, obese individual, you're going for something like the examination from the anterior superior iliac spine. In case of a child that is going to be having age less than 1 year, that means an infant, we may prefer to go in for a superficial bone like the tibia. What we need to remind ourselves is that how exactly is the appearance of a normal smear going to be looking like. So you'll be having the presence of RBCs, which are going to be having a central 1/3 pale area. Size of RBC is going to be similar to that of a small lymphocyte. And you're going to be having sometimes variation in the size and the shape of the RBCs. Whenever we are talking about RBCs are going to be having a mean volume between 80 to 100 femtoliters. When there is going to be too much of a variation in the shape of the RBCs, that is given the name of poikilocytosis. So variation in the shape, poikilocytosis, because of which RBCs can be having the presence of elongated shape, or they can be having what is being termed as pencil-shaped cells. Any kind of a variation in the size of the RBCs is what is termed as N-isocytosis. We do have an index by which we calculate the N-isocytosis, and that index is given the name of RDW, that is red cell distribution width. Having a look at the normal value of the red cell distribution width, it is going to be between 11.5 to 14.5. Whenever we are talking about the process of erythropoiesis, it is taking place under the influence of a secretion of a hormone which is called as erythropoietin. This erythropoietin hormone is going to be acting on a precursor cell in the bone marrow which is given the name of a proerythroblast. This is going to be giving rise to the erythroblast. Then we are going to be having the formation of a normoblast. Normoblast is going to be giving rise to cells which are going to be given the name of a reticulocyte. And finally, we get formation of mature RBCs over here. What we need to remind ourselves is that the first appearance of hemoglobin can be detected only and only electron microscopically, and that can be seen in case of a cell that is going to be given the name of an erythroblast. Routine detection of hemoglobin can be done with the help of the stains, and that is going to be possible only in case of a polychromatophilic normoblast. The polychromatophilic normoblast is also called as intermediate normoblast. So normoblasts are of three types: early, intermediate, and late. Initially, they are going to be having a basophilic appearance, then they are going to be having a polychromatophilic appearance, and then they are going to be having an orthochromic appearance. So that's a sequence of the normoblast: early, intermediate, and late. Having a look at the reticulocytes, which are the example of the first non-nucleated cells, they are having the presence of a reticulin mesher, and reticulocytes are detected with the help of a fresh supravital stain. The best stain which can be useful for picking up a reticulocyte happens to be new methylene blue. Now, why is reticulocyte so important? Because that can be giving us an indicator for the activity of the bone marrow. So instead of going in for a more, I would say, complex procedure, say for example, the patient requires hospitalization, that can involve more finances, that can result in a possible complication like bone marrow examination, relatively suitable alternative, especially in the peripheral parts, can be going in for the reticulocyte counts. When you talk about the reticulocyte counts, we need to be familiar with the terms such as percentage reticulocyte count, and better still, I would recommend you to be familiar with the term which is called as CRC, that is corrected reticulocyte count. So when you calculate the percentage of reticulocytes, this is what is to be multiplied by the patient's hematocrit. That's what is kept as in the numerator, and in the denominator you will be having the presence of the average normal hematocrit, which is having a value of 45. This corrected reticulocyte count takes into fact that there is going to be compensatory erythropoiesis in patients who are going to be having anemia. A still better thing that we need to remember over here is the concept of what is being termed as the reticulocyte production index. Reticulocyte production index, which is having a normal value of 2 to 3, will tell us what is the status of activity of the bone marrow. When we are talking about the reticulocyte production index, it is simply calculated as corrected reticulocyte count, and in the denominator you would be having the presence of maturation factor. Average maturation factor value that is to be taken for the exams happens to be a value of 2. Why that is important is once you calculate the corrected reticulocyte count divided by maturation factor, that means you have calculated the reticulocyte production index. If the value of this index is less than 2, then that means the bone marrow is underactive. It is a hypoproliferative state. However, in case of a situation when the activity or the value of the index is going to be more than 3, that suggests a hyperproliferative state. That means the bone marrow is working overtime. Classical conditions in which the bone marrow is going to be underactive can be nutritional deficiency, say for example iron deficiency anemia. And an example of a condition where the bone marrow goes into an overdrive, it is in a hyperproliferative state, is going to be, say for example, a patient who's going to be having something like hemolytic anemia. So there is a compensatory increase in erythropoietic activity. There are different ways by which we classify anemias, but one of the ways can be looking at the size of the RBCs. If the RBCs are going to be small in size, that is what is being termed as microcytosis, and that can be caused because of multiple conditions, out of which we need to remember about the 4 classical conditions, that is CETA. Clinically, what we observe globally as well as in our countries, the most common reason for development of a microcytic hypochromic anemia happens to be iron deficiency anemia. As and when we are talking about normocytic anemia can be remembered with the name of Lord Ram. So we can be talking about a patient having renal failure, we can be talking about anemia of chronic disease, myelofibrosis as well as metastasis. What you need to remember over here is, if you observe carefully, the name of anemia of chronic disease features in both normocytic normochromic anemia. It is also present in as a cause of microcytic hypochromic anemia. Why that happens? More common or more number of patients who are having anemia of chronic disease are going to be having normocytic anemia. But some of these patients, about 25% of the patients, can be having microcytic anemia as well. We do have conditions where the patients are going to be having the presence of macrocytosis. So they are having the RBCs which are going to be having a volume more than 100 femtoliters. That can be classically observed in case of cells which are going to be seen in a patient who is going to be suffering from a liver disease. Can be seen in case of an individual who is going to be having a metabolic problem, something like hypothyroidism. May be seen in case of a patient who is going to be suffering from myelodysplastic syndrome, or can be seen in case of other conditions where there is going to be presence of megaloblastosis, including B12 deficiency, folic acid deficiency, drugs like phenytoin, alcohol exposure, or can be seen in case of an individual suffering from a condition like orotic aciduria. Out of all the causes of anemia, the commonest reason happens to be deficiency of iron. And that is where most of the question exams are going to be framed. So let us have a quick look at the iron metabolism. When you talk about iron metabolism, the chief site for the absorption of iron in the body happens to be the gut. And in the gut, you are going to be having the chief site of absorption of iron, that is going to be duodenum. Iron is going to be absorbed in the gut from the ferrous form, and we are having the presence of iron in the ferrous form in the diet. However, if any iron is present in the ferric form, that can be reduced with the help of a molecule that is present in the intestinal cell, which is given the name of cytochrome reductase. Cytochrome reductase. Once iron enters inside the intestinal cell, it is going to be facilitating in the body. The entry is facilitated by the presence of a transporter that is given the name of ferroportin. Once the ferrous form of iron has come inside the body, it is going to get oxidized so that it can be transported properly. And the oxidation process is going to be done with the help of molecules which are ceruloplasmin and hephaestine. So when we want to absorb iron from the lumen, it has to be present in the ferrous form. When it has to be transported, it has to be reconverted into the ferric form. There are factors which are going to be helpful in absorption of iron, particularly hydrochloric acid, ascorbic acid and amino acid. Any substance present like phytate, carbonate, tannic acid or tetracyclines are inhibitory to the absorption of iron. Once iron is going to be entering inside the blood, it would require the role of a plasma protein which is given the name of transferrin. Theoretically, transferrin can be having the presence of 6 iron attachment sites. However, only practically 2 iron molecules are going to get transported with transferrin. This transferrin is responsible for contributing to the certain terms that we are using in context of iron profile, percentage transferrin saturation, serum iron and TIBC. Once iron is going to get transported in the blood, it is going to be taken up inside the storage sites. The storage sites would include the hepatic tissue as well as the bone marrow macrophages. Why? Because they would be having the presence of the transferrin receptor. Storage form of iron is what is given the name of ferritin. And we do have a super condensed form of ferritin about which we made a mention of earlier, that is hemosiderin. This hemosiderin, as you may be able to recall friends, can be picked up with the help of a special stain that's given the name of Prussian blue, and the reaction was called as Pearl's reaction. So all in all, this is the basic background of iron metabolism that we need to have an idea. Now what exactly is going to be responsible for the development of iron deficiency can be because of primarily nutritional deficiency, or there can be other conditions like worm infestations, or for that matter chronic bleeding from the GI tract or the urinary tract, or the patients could be having malignancies. Right? Now, any patient who's going to be having the presence of an iron deficiency is going to be having the presence of decreased work capacity. They're going to be having the presence of fatigue. They will be having presence of difficulty in breathing as well. Sometimes patients can be having in severe conditions palpitations. They can be having changes with respect to the epithelial cells. They can be having loss of hair, alopecia, or they can be having presence of spoon-shaped nails like koilonychia. Some people, especially children, are going to be having altered eating habits. So they would like to eat something like ice, or they would like to eat something like mud. That's called as pica. If we take the blood sample of these individuals and observe them microscopically, we would be having characteristically the presence of small sized RBCs. And these RBCs are going to be having less quantity of hemoglobin. So that is going to be an example of a microcytic hypochromic red cells. Microcytic hypochromic red cells can be picked up because they are going to be having more than 1/3 area which is going to be pale in them. Because of the different sensitivities, we are going to be having a variation in the size and shape of RBCs as well. So there is obviously going to be anisocytosis and poikilocytosis. Now, what is going to be the findings that are going to be seen in a patient suffering from iron deficiency anemia? Patients having iron deficiency anemia initially are going to be having a decrease in the concentration of serum ferritin. So storage form of iron is going to be reduced first. In due course of time, serum iron is going to be going down. Patients are going to be having a decrease in the percentage transferrin saturation as well. But as we understand, there is one parameter which is going to be increasing in patients having iron deficiency anemia, and that is going to be total iron binding capacity. We are having a situation at times wherein we wish to differentiate between a condition like iron deficiency anemia and other causes of microcytic hypochromic anemia. So one way by which we can do this is in writing down the different changes that are seen in the iron profile of the patients. Even though I can talk about that subsequently, but I just want you to remember, in patients having anemia of chronic disease, there is inflammation. And because they are having inflammation, so these patients, what they are going to be having is, there is going to be increase in their ferritin. Their serum iron values are going to be less, percentage transferrin saturation is less, and they are going to be having a decrease in their total iron binding capacity. Any patient who is going to be having thalassemia trait, it's an example of a globin problem. So these patients are going to be having nearly normal values of iron in them. As and when we are making a reference to patients who are going to be having sideroblastic anemia, it's an example of an iron overload condition. So just like we talk about that English phrase, water everywhere, not a drop to drink, in context of the sea travel, similarly sideroblastic anemia. Lots and lots of iron may be available, but it cannot be utilized because of genetic reasons or acquired reasons like lead poisoning or pyridoxine deficiency. So patients are going to be having the presence of the iron containing cells in the bone marrow, which are given the name of sideroblasts. They can also be having iron profile, which is suggestive of iron overload. So these individuals are going to be having the presence of increased serum ferritin, increased serum iron, increased transferrin saturation, and they are going to be having decrease in the total iron binding capacity. One of the major challenges that is observed in the practices to differentiate between patients having iron deficiency anemia and patients who are going to be having thalassemia trait. This typically happens when the patients are going to be residing in an area in which the prevalence of thalassemia is relatively high. One way by which we can do this is performance of a test that is given the name of Mentzer index. Mentzer index is calculated by a simple formula by which in the numerator you are going to be keeping the value of mean cell volume. In the denominator, you are going to be keeping the value of RBC count. When we calculate the Menzer index, if the value of Menzer index, fact number 1, it is useful for differentiation of iron deficiency anemia and thalassemia trait. If the value of Menzer index is going to be more than 13, then this is what is going to be associated with iron deficiency anemia, friends. And if the value is going to be less than 13, that is going to be associated with thalassemia trait. So easy for you to remember, I for iron deficiency anemia, I for increased value, that means value more than 13. Or you can remember thalassemia automatically has phonetically the word less in it. So the value when it is going to be less than 13, that is going to be a feature of thalassemia. Genetic testing out of these 4 conditions is primarily applicable for making a diagnosis of something like thalassemia trait. We sometimes can be going in for an alternative test that is given the name of serum transferrin receptor and log ferritin ratio. This may be handy for differentiation of patients having iron deficiency anemia and patients having anemia of chronic disease. In case of patients who are going to be having the presence of the ratio, which is going to be having because of iron deficiency anemia, the ratio is going to be having a value more than 1.5. And if you look at the value of the ratio in case of patients having anemia of chronic disease, that is going to be less than 1.5. So IDA patients have value more than 1.5. AOCD patients are going to be having a value that is less than 1.5. Only for INICT, the same thing can be given to you in the form of a plot-based question that's given the name of the Thomas plot. So what we understand is that in case of a patient who's going to be having the presence of iron deficiency, the representation is going to be in the right lower quadrant because the ratio is going to be having a higher value more than 1.5, and individually if you're looking at the reticulocytes, the content of hemoglobin is going to be less. Any patient who's going to be having iron deficiency is going to be having more availability of protoporphyrin. So the patients are going to be having free erythrocyte protoporphyrin levels which are going to be increased in them. That's a feature of iron deficiency anemia. Once we are clear with this kind of a concept, we just have a word or two about the sideroblastic anemia. Now, sideroblastic anemia is an example of a condition in which, as I described to you earlier, there is going to be a deposition of iron in the perinuclear mitochondrial region. So that is the reason why it is going to be associated with development of ringed sideroblasts. The causes of sideroblastic anemia are important. One important cause can be alcohol consumption. Another can be because of a heavy metal like lead poisoning. A third can be the patient is on anti-tubercular therapy, pretty relevant in our country. So patient is going to be having this because of isoniazid side effect. He could be having it because of the presence of a myelodysplastic syndrome, or he could be having it because of a genetic cause. Reason or association between isoniazid administration and sideroblastic anemia would be the development of a deficiency of pyridoxine. So in such a situation, if a patient is having sideroblastic anemia because of pyridoxine deficiency, obviously administration of pyridoxine is going to improve the symptoms of the patient. That is what is to be remembered for the example of an image-based question asked in the exam. Once we have taken care of this, we just quickly have a discussion about a word or two about anemia of chronic disease. This condition is going to be associated with chronic inflammation. In this condition, there is increase in the secretion of cytokines. These cytokines can result in development of normocytic normochromic anemia. That's fact number 1. Inflammation associated normocytic normochromic anemia. That can be one possibility. Possibility number 2 is that in patients having anemia of chronic disease, there is increase in the formation or synthesis of hepcidin. Hepcidin is an example of a negative iron regulatory protein. Negative iron regulatory protein. Why do we say it is an example of a negative iron regulatory protein? Because hepcidin is going to decrease or block the activity of ferroportin. Hepcidin reduces the activity of ferroportin. So it is easy for you to understand that iron will not be entering inside the blood. As a result of which the patients are going to be having the development of small sized and pale RBCs. So that is why we say anemia of chronic disease can also result in development of microcytic hypochromic anemia. So the role of hepcidin is what you need to remember for the exams, and its inhibitory influence on ferroportin is what is even more important. Not to forget, the more common type of anemia that you see in a patient having anemia of chronic disease happens to be the normocytic normochromic anemia, right? Having said that, we just need to be familiar with the other important types of anemias that are observed, which is going to be megaloblastic anemia. Megaloblastic anemia means that there is an increase in the size of the RBCs and there is going to be nuclear maturation defect as well. This can be causing an involvement of multiple cells in the bone marrow. So what is going to be seen in these patients would be that if you look at the bone marrow of these individuals, the number of cells in the bone marrow are going to be more. But once you're looking at the peripheral smear, or if you just look at the cells or the count, the number of cells are going to be less. So bone marrow is going into a state of dry. That means hypercellular marrow, but outcome is not going to be as good. So it is going to be called as ineffective erythropoiesis. Apart from this, because of B12 and folic acid deficiency, patients are going to be having certain changes which are observed in the cells. One of the important changes which are asked in the exam time and again is the presence of special type of change in the neutrophils, which is given the name of hypersegmented neutrophil. Normal neutrophils are having 3 to 4 nuclear lobes, but if the number of nuclear lobes in a neutrophil is more than 5, that is what is being termed as a hypersegmented neutrophil. So this is an example of a hypersegmented neutrophil that you can characteristically see. Apart from that, you can make out RBCs may be big in size, but they can be having a variation in their shape and their size. So anisocytosis, poikilocytosis will also be seen over here. What is going to be the important fact by which we can differentiate between whether my patient is having a B12 deficiency or folic acid deficiency? Patients who are going to be having B12 deficiency classically are going to be having a problem in the formation of myelin. So these individuals are going to be having the presence of a feature which is going to be useful in the exams, presence of neurological symptoms. Because of certain biochemical reactions which are going to be affected, patients are going to be having increased value of serum methylmalonyl coenzyme. Megaloblastic anemia without any neurological symptoms is a feature of folic acid deficiency. Also remember that the methylmalonyl coenzyme levels remain normal in an individual having folic acid deficiency. Whenever we are going to be talking about the presence of methylmalonyl coenzyme in the urine, that can only be seen in a patient having B12 deficiency. It is never seen in a patient having folic acid deficiency. Something which is not going to be useful in differentiating between the B12 deficiency and folic acid deficiency. So that means in both these conditions, the test is going to be coming out to be abnormal. Homocysteine levels are elevated in both of them. Some hints which are given in the exam question and which are observed practically, which will help you understand why is a patient having B12 deficiency and why is a certain subset of patients having folic acid deficiency can be a question that is making a mention of a patient who is having a dietary habit. He happens to be a vegan. Vegan individuals do not take anything coming from the animal food. Therefore, they are at higher risk of development of B12 deficiency. B12 absorption requires the functional role of stomach. It requires the role of pancreas. It requires the role of gut bacteria. It requires the role of ileum. So any patient having a gastric issue, any patient who's going to be having autoimmune conditions, say for example, pernicious anemia, pancreatic insufficiency, ileal disorders, Crohn's disease, tuberculosis, or for that matter, gut overload, bacterial overgrowth syndrome, they are at higher risk of suffering from B12 deficiency. We must also remind ourselves as a microbiology link that people who are going to be having a consumption of raw seafood, fish tapeworm may be seen in them. And this fish tapeworm, which is Diphyllobothrium latum, can be associated with B12 deficiency. Thankfully, what we need to remember over here is that B12 deficiency is not going to manifest pretty early. It takes usually years and years of non-consumption of B12 for this deficiency to take place. However, as and when we are making a mention of folic acid deficiency, if we talk about the nutrients after iron deficiency, folic acid deficiency is going to take place more commonly, maybe exacerbated or maybe more commonly observed in people who are not going to be having any regular intake of folic acid. So the question will say that the individual is having the preference for eating something like a junk food, maybe the pizzas, the burgers, the colas, and he's not consuming the fresh fruits and vegetables at all. It can also be seen because of a situation when the individual is going to be having excessive consumption of certain types of materials, say for example drugs, alcohol, can be seen because of consumption of oral contraceptives or anti-epileptic drugs like phenytoin. Now, whenever we are going to be having a patient having B12 deficiency, the patients can be having a development of a classical lesion that is associated with demyelination of the posterior columns. This demyelinating lesion of the posterior column is given the name of SACD, that is subacute demyelination, combined degeneration of the spinal cord. This is going to be associated with B12 deficiency. Another important finding to be remembered is in patients who are going to be having an autoimmune cause of B12 deficiency. What was that? Pernicious anemia. These patients having pernicious anemia, though it is thankfully a rare condition in India, but this condition is going to be associated with overactivity of the tyrosinase enzyme, and that is going to be responsible for causing development of hyperpigmentation of the knuckles in the patients. So pernicious anemia is going to be associated with hyperpigmentation of the knuckles, of course, along with all the other findings that I made a mention of with respect to B12 deficiency. So that is what we need to remember so far as the differentiation between B12 deficiency and folic acid deficiency is concerned. Whenever we wish to treat a patient who is going to be having megaloblastic anemia, it is always preferable that we give B12 and folic acid together. If they have to be given in a sequential manner, then B12 has to be given first and then later on folic acid is added. Never ever give folic acid initially in an undiagnosed case of megaloblastic anemia. Otherwise, you are likely to cause worsening of the neurological symptoms in the patient. So these basic facts are what we need to remember over here. Then we need to have an idea about the second category of the anemias apart from nutritional deficiency anemias, that is hemolytic anemias. We have a wonderful classification of hemolytic anemias wherein we look whether there is an intracorpuscular cause or whether there is an extracorpuscular cause. When we are talking about the differentiation, when we're looking at the intracorpuscular causes, we have to see whether it is an example of an inherited condition or whether it is an example of an acquired condition. Inherited condition can include the membrane disorders, enzyme disorders or hemoglobinopathies. Inherited conditions are more, and we have just one condition, therefore it is easier and important for us to remember, which is intracorpuscular and acquired in nature, that is PNH, paroxysmal nocturnal hemoglobinuria. Beyond that, if you are going to be looking at conditions like RH incompatibility, ABU incompatibility or immune hemolytic anemia, they are example of immune mediated extracorpuscular causes of hemolytic anemia. And then if you are talking about exposure to certain types of toxins, say for example clostridial toxin or for that matter septicemia, or there is a mechanical damage, then that would be an example of a non-immune mediated extracorpuscular cause. Whenever we are talking about the conditions, we need to remind ourselves of these conditions and the salient features one by one. So I'll start off the discussion with the intracorpuscular conditions. The first condition I wish you to be familiar with is hereditary spherocytosis. Hereditary spherocytosis would be an example of a condition in which the patients are going to be having the presence of an autosomal dominant problem. This condition is characterized by a mutation most commonly observed in case of a red cell membrane cytoskeletal protein which is called as enchirin. Patients are going to be having change in the shape of the RBCs. RBCs are going to become chubbier. They are going to become spherical. So the RBCs are going to be having a loss of their central pallor, absence of central pallor, the keyword for your exam questions. Since RBCs are become chubby, they are going to be having a destruction inside the spleen, and therefore the patients are going to be having hemolysis. That explains why the patients are going to be having the presence of a jaundice, anemia and splenomegaly. There is a hemolytic anemia, so jaundice is observed along with anemia, and because the site of destruction is spleen, so splenomegaly is going to be observed. One way of looking at this condition is the patients are having spherical RBCs, but there can be other conditions also where spherocytes can be seen. Therefore, we are going to be performing confirmatory tests to see this condition, and the confirmatory test by which we can pick up this condition is flow cytometry. Even though we must remember that we use a special stain with respect to flow cytometry which is given the name of eosin 5-maleamide. So EMA flow cytometry is considered as investigation of choice for hereditary spherocytosis. If the patient is having too severe an anemia, we may think in terms of going in for the surgical removal of the spleen in such patients. However, it comes with its own risks and disadvantages. If you remove the spleen in case of an individual, that would be associated with higher risk for development of infections caused by capsulated organisms. Second fact, even if you are going to be removing the spleen of an individual, you would not be having any change in the shape of the RBC. So RBCs will still remain spherical, even though the severity of anemia definitely is going to be improved. So any question in the exam which makes a mention of the RBCs, which is going to be having the presence of directly makes a mention of spherical RBCs, or it says RBCs which are not having a central pallor, that's what is to be remembered for hereditary spherocytosis. We need to be familiar that the commonest reason for development of spherocytosis, however, happens to be autoimmune hemolytic anemia. Second important cause of hemolytic anemia can be because of an enzyme deficiency, and this enzyme deficiency is G6PD deficiency. We must remind genetics links over here. It's an example of an X-linked recessive condition. Any X-linked recessive condition, friends, is going to be more commonly observed in case of males. What's the normal function of G6PD enzyme? The normal function of the G6PD enzyme is it is going to be eventually responsible for the formation of the reduced glutathione, and the reduced glutathione is responsible for acting as a defense mechanism. Reduced glutathione is going to protect the RBCs against any kind of an oxidative damage. Therefore, it is easy for us to understand whenever a person is going to be having G6PD deficiency, RBCs become extra sensitive to oxidative stress. G6PD deficiency, RBCs become extra sensitive to oxidative stress. Now, this kind of an oxidative stress can be seen because of multiple reasons. That can be seen because of, let us say, certain types of infections. That can be seen because of certain types of food materials like fava beans, or that can be seen because of certain types of drugs, especially drugs like primaquine. If there is too much of an oxidative stress, it can result in desaturation of the hemoglobin, and the denatured hemoglobin is given a special name. It is being given the name of Heinz body. Also, RBCs are going to be having an alteration in their shape. So when they are going to be passing through the spleen, they are going to be having an appearance which is being described in the books by the name of bite cells or degmacytes. So coagulum of the RBCs shift in a manner that the RBCs have an appearance that's given the name of a bite cell or a degmacyte. So any question in the exam where the question talks about a patient having a history of an intake of certain food materials like fava beans, intake of drugs like primaquine, and just about after 48 hours, patient is having the presence of passage of altered color of urine, or the question says peripheral smear was showing you presence of Heinz body, it was showing you presence of degmacytes, or it is going to be showing you presence of blister cells, that's automatically an indicator for G6PD deficiency. Please remember, G6PD deficiency is responsible or having an association with, it can result in both intravascular as well as extravascular hemolytic anemia. There's a good point, a silver lining in case of G6PD deficiency. These patients are going to be having relatively lesser chance of suffering from Plasmodium falciparum malaria. We also need to be familiar with the fact, whenever we are talking about something like G6PD deficiency, thankfully, it's an example of a self-limiting condition. Having said that, we talk about the next important reason for development of hemolytic anemia, which is an example of a hemoglobinopathy, that is sickle cell anemia. Sickle cell anemia classically is going to be seen because of a point mutation, and because of which there is going to be a replacement of amino acid glutamic acid by valine at the 6th position of the beta globin chain. This is going to be responsible for formation of an abnormal hemoglobin, that is hemoglobin S, and this hemoglobin S is going to be having altered solubility. Hemoglobin S having altered solubility is going to be responsible for causing change in the shape of the RBCs. Whenever there is hypoxia, whenever there is dehydration, RBCs are going to change their shape. They are going to become sickle shaped. Such RBCs are going to be having another problem, that their mechanical fragility is going to increase. However, their osmotic fragility is going to be less. So osmotic fragility is less, but mechanical fragility is going to be increased. Now, why is this associated with the importance of knowing about this association with dehydration and hypoxia? Whenever there is going to be presence of hypoxia and dehydration, RBCs are going to occlude the vessels, and this can result in development of a condition which is given the name of vaso-occlusive crisis. Majority of the sickle cell anemia patients, therefore, who are going to be having this autosomal recessive condition are going to be having the presence of a painful crisis that can be responsible for causing involvement of hands and feet. So that's called as hand-foot syndrome. Patients can have a presentation, Afro-American child, who is going to be having the presence of a non-healing leg ulcer around the medial malleolus. Patients are going to be at higher risk for development of infections. They are going to be having initially an increase in the size of the spleen, splenomegaly, but in due course of time, because of the vaso-occlusion, the spleen is going to get replaced by fibrous tissue. So that is what is going to be associated with the term autosplenectomy. When we are talking about fibrotic areas in the spleen, they may be associated with calcium deposition as well. And if there is a calcium deposition in the fibrotic areas, we associate it with the term that is Gandhi-Gamna body. Patients who are going to be having sickle cell anemia can also be having the presence of development of something like the crew-cut appearance in the X-ray skull. They can be having the presence of avascular necrosis of the bone. Male patients can be having a high risk for development of priapism as a complication. Some of the patient can go in for a crisis like hemolytic crisis or sequestration crisis as well. And the patients at times, please remember, are going to be confirmedly diagnosed with the help of the genetic testing. The genetic testing can be done with the help of gene analysis, and this is to be remembered because this gene analysis will show you exactly that the patients were having the presence of a point mutation. So that's about sickle cell anemia that we need to remember. Of course, the easiest thing which can be done if you have a known patient of sickle cell anemia is keep them hydrated, keep them oxygenated, and if it is too severe a condition, of course, give them the symptomatic treatment like analgesics, and you have to give a drug at times which is hydroxyurea. Whenever we are going to be talking about the other important example of a hemoglobinopathy, that is thalassemia. Thalassemia can be affecting either the beta chain or the alpha chain. It is the beta thalassemia which is far more prevalent in comparison to alpha thalassemia. And the reason attributed is that beta thalassemia is caused because of gene mutation. alpha thalassemia is caused because of gene deletion. Whenever we are talking about beta thalassemia, the clinical presentation of the patient can be in three subtypes. Either the patient is going to be having a very severe kind of a condition, so that is what is going to be given the name of beta thalassemia major. Such patients have a hemoglobin which is going to be typically less than 7 gram per deciliter, and such patients are going to be requiring regular blood transfusions since an early age. Classically, after about 6 months of age, they are going to be requiring 2 to 3 transfusions every week. Whenever we are talking about a patient who is going to be having beta thalassemia intermedia, the condition is thankfully relatively less severe in comparison to thalassemia major, but this question will make a mention of patient having a hemoglobin value anywhere between 7 to 10, and he may have a history of ectopic off and on blood transfusions, but not too many, not as severe as you would expect in case of thalassemia major. What we need to remember as a physician is going to be about a thalassemia which is given the name of thalassemia minor, which is also being referred by the name of thalassemia trait. Thalassemia trait patients are going to be having an issue that they're absolutely asymptomatic. Thalassemia trait patients are going to be absolutely asymptomatic. So the issue with them is that even a lot of times they don't know that they are having some kind of a problem. Why that becomes clinically significant is they are asymptomatic, they don't know they have an issue, the hemoglobin is going to be just about around 10, so 10.2, 10.4, 10.5, something of that sort, and it's a very mild kind of an anemia that they're having. The issue that may arise with them is that if one individual, be it a boy or be it a girl, marries another individual who is also having thalassemia trait, that can happen in certain geographical areas of our country where thalassemia is common. Say for example, Sindhis, say for example, Lohanas, say for example, in the Telangana region, say for example, in the Punjabis, say for example, the West Bengal. If one individual with thalassemia trait is going to marry another individual with thalassemia trait, there's a 25% chance that the baby that they will be having would be suffering from thalassemia major. Remember, major is actually a major problem in the life. So, unfortunately, if that is a situation, then that is going to be destroying the quality of life of the individual. So that's the reason why we keep on screening and we try to diagnose as much these people as possible and try to spread awareness about this kind of a disease. Now at a genetic level, what we need to remember over here is that the reason for development of thalassemia as per the genetic analysis which has shown us is that majority of the patients are going to be having an issue that is going to be affecting the intervening sequence 1-5. So that is as per the data at the topmost institute, tertiary care institute, that we need to have an idea. Before I talk about alpha thalassemia, I would just request you to have an idea about what exactly is a clinical presentation of a patient having thalassemia. So patients having thalassemia are suffering from a genetic disease, therefore they usually have a presence of a positive family history. The commonest mutation as I discussed with you is intervening sequence 1-5 trouble. The patients are having a severe anemia. So the site of erythropoiesis is going to shift from the bone to the extramedullary sites, and therefore the patients are going to be having the involvement of the facial bones, because of which they have a chipmunk facies. Liver and spleen are going to be having extramedullary hematopoiesis as well. So there is hepatosplenomegaly, and because of involvement of the facial bones, including the skull, the patients are going to be having the presence of a hair on end appearance. As and when we are looking at the peripheral smear from the blood sample taken from the individual, that is going to be showing you presence of microcytic hypochromic cells. Hemoglobin is very less. Membrane is too much. If there is too much of membrane, that can be responsible for the formation of a special appearance of the RBCs, which is given the name of the bull's eye appearance. The bull's eye appearance. So bull's eye appearance, which is also being given the name of target cells. So whenever you have a patient who is going to be having this severe anemia, hepatosplenomegaly, chimpanzee-like faces, hair on end appearance, and target cells, anisocytosis, poikilocytosis, and of course, if it is thal major, a regular history of blood transfusion, you would be obviously making a diagnosis of this condition fairly easily. Talking then about a condition that is given the name of alpha thalassemia. Alpha thalassemia, as I reiterated, is going to be seen because of gene deletion. Now, alpha chains are being produced by 4 genes, right? So, alpha genes are present on, as we are aware, on the chromosome 16, and they are going to be associated with deletion of a gene. If there is a single gene deletion, or if there are 2 genes which are going to be deleted, majority of the patients are going to remain asymptomatic. But when there is going to be deletion of 3 genes, let me just make a mention of this. If there is going to be a deletion of 3 genes, that is going to be represented as something like this. If there is going to be a deletion of 3 genes, that is going to be represented as like this. This is going to be responsible for causing a severe kind of an anemia, just like beta thalassemia. That is going to be associated with development of a more severe anemia. The problem is that in such a situation, alpha chains are not available. So the beta chains are going to be forming a tetramer. When the beta chains are going to be forming a tetramer, these tetramer are going to be having a special appearance that is given the name of golf ball inclusions. Sometimes the babies can be having, a fetus can be having an unfortunate situation where all the 4 genes are going to get deleted. And in such a situation, a lot of times this condition becomes lethal for the baby. And that is what is going to be responsible for causing a development of a non-immune hydros fetalis. So hydros fetalis, the fetal unfortunately in a lot of situations doesn't survive and it is going to die in utero itself. That is what we need to remember over here. Having said that, just look at the important perspective things with respect to alpha thalassemia. So alpha thalassemia, as per the data shows, is going to be seen because of gene deletion, and the deletion is most commonly going to be seen at the level of 3.7. When we are talking about alpha thalassemia, you could be having the presence of HBH inclusions. As I made a mention, alpha chains are not available, so beta chains are going to produce a tetramers amongst themselves that is responsible for a hemoglobin that is called as HBH. This HBH precipitates inside the RBCs, and on the supravital staining, that is going to be having an appearance that is called as the golf ball appearance. So pretty much dot like appearance, the golf ball appearance that is going to be observed over here. Now what we did is discuss, in case of a patient having thalassemia trait, a lot of these patients are asymptomatic, right? So particularly when there's a lady who is expecting, who's coming to your clinic, and it is an institutional kind of a setup, and we are having her hemoglobin, which is not increasing even after giving iron. We suspect that she could be having something like thalassemia. So we may go in for a screening test. The screening test that we need to remember over here is given the name of Nestrov test. Nestrov test can be an image-based question. What you need to remember over here is that in case of the control sample, you can easily observe the lines. But if the patient is going to be having thalassemia trait, the line is something which is not going to be visible. So normal sample, if it is taken, the line is visible at the background because of the hemolysis which is taking place when you put the blood sample in a dilute solution of normal saline. And if it is a thalassemia trait patient, the black line is not visible. So when you have this is a positive screening test. That means the patient is likely to have thalassemia. So we can go in for other investigations, confirmatory investigations like genetic analysis. Second fact, if you have a patient having microcytic hypochromic anemia, we discussed earlier, what is the commonest cause in our country? That happens to be iron deficiency anemia. It would respond to iron therapy, no doubt. But if you have a condition in which the patient is having a microcytic hypochromic anemia, iron non-responsive, and you suspect that the patient could be having a thalassemia, to differentiate between thalassemia and iron deficiency anemia, we did make a mention of a index that's given the name of Mendzer index. That index is given the name of Mendzer index. Reminding you, how do we calculate Mendzer index? MCV in the numerator, RBC count in the denominator. If the value of the index happens to be more than 13, it is suggestive of iron deficiency anemia. And if the value of this index comes out to be less than 13, that is suggestive of thalassemia. So this Mendzer index is pretty much useful as a tool for differentiating between iron deficiency anemia and thalassemia trait. So you may get lots and lots of clinical questions giving you the values of MCV, giving you the value of RBC count, having a presentation in the form of a microcytic hypochromic anemia, and then you, based on your experience or calculation of Mendzer index, you will be able to say whether it is thal trait or whether it is ID. If it is a patient having iron deficiency anemia, the further investigations will require ferritin and iron profile investigations. If it is a patient having thalassemia trait, the further investigations can require the genetic analysis, or you can go in for hemoglobin estimations. Remember a basic fact, in case of a normal adult, the predominant hemoglobin that we have is HbA, that is what we are looking at. In case of a patient who is going to be suffering from thalassemia major, the predominant hemoglobin is not to be answered as HbA, it is rather to be answered as HbF. And whenever we are suspecting a patient to be suffering from thalassemia trait or thalassemia minor, the hemoglobin that we are focusing on is HbA2. And characteristically, this HbA2 is going to be having a value which is more than 3.5 gram per deciliter. So, 3 different conditions, 3 different subtypes of hemoglobin that we are looking at as and when we are focusing on a condition in which the individual maybe happens to be a normal individual, or an individual who is going to be suffering from thalassemia major, or an individual who is going to be suffering from thalassemia trait. So that is what we need to remember over here, right? Having had knowledge about this particular thing, we can then talk about an example of a intracorpuscular acquired cause of hemolytic anemia. This condition is going to be given the name of paroxysmal nocturnal hemoglobin urea. This condition is classically going to be seen because of presence of a PIGA gene defect. And because of the PIGA gene defect, patients are going to be having reduced expression of CD55 and CD59. So these patients are going to be having too much of complement mediated damage to the cells of the blood. That's why the patients are going to be having a classical triad, hemolytic anemia. They would be having the presence of pancytopenia, and they are going to be having altered function of the platelets, because of which they are going to be having thrombosis. Why should we be familiar with this thrombosis? Because this thrombosis can complicate the hepatic circulation. It can result in development of a condition that is given the name of Budd-Chiari syndrome. Why is Budd-Chiari syndrome a complication which is bad for news for a patient? Because this can precipitate mortality in the patients. Now, whenever we are talking about a patient who's going to be having PNH, it has been shown to be having an association with a condition like myelodysplastic syndrome. PNH, the average age of presentation of the patient, it is usually not going to be seen in the childhood. It is going to be seen in the adults. The question will make a mention of the fact that the patient, when he is sleeping in the night, no issues. But when he gets up in the morning, then he is having a passage of a dark colored urine. So the urine sample of the patient is very dark when it is a first urine sample. As time passes by, as he is going to be passing more urine, the urine is going to be appearing lighter. When we are talking about the confirmation of this condition, that can be done with the help of a test that is given the name of flare flow cytometry. Now, because it is an acquired problem, so some cells are normal, some cells are abnormal. Therefore, what you are going to be having over here is that people who are going to be suffering from PNH, they are going to be having the presence of two types of cells. Some of the cells in these individuals are going to be abnormal, and some of the cells in these individuals are going to be normal. So this represents a normal cell with the red color, and what I am representing with the blue color over here is representation of the cells which are abnormal. So two types of cells present in the same individual, that is characteristic in context of PNH. The type of flow cytometry that we are using in these patients is not to be confused with hereditary serocytosis. This one is a flare flow cytometry, right? When we are talking about the other condition, we need to be familiar with a condition in which there is formation of antibodies against the RBC antigens. If there is antibody formation against RBC antigens, this condition is given the name of immune hemolytic anemia. Immune hemolytic anemia can be of two types. If antibodies are going to attach at 37 degrees Celsius, it is called as warm autoimmune hemolytic anemia. If it is going to be attaching at a cold temperature, it is called as cold autoimmune hemolytic anemia. Majority of the qualitative nature of the antibodies in case of the warm subtype of hemolytic anemia is going to be IgG. So we remember it, G for garam, G for Goa, Goa is hot, of course, that's what we said. And sometimes it can be IgA. If we're looking at cold immune hemolytic anemia, most of the patients are going to be having the qualitative nature of the antibody, which is IgM. Very uncommonly, very rarely, it can be IgG. Conditions which are associated with warm autoimmune hemolytic anemia can include, sometimes we do not know the cause, so that is idiopathic. Sometimes it can be because of autoimmune disorders like SLE, or it can be seen in case of cancers like CLL, or it can be because of drug exposure like alpha-methyl-dopa and penicillin. So patients are going to be having, let us say, a history of alpha-methyl-dopa intake or penicillin intake, or patients are known case of CLL, and then they are going to be having the presence of a antibody formation. When there is antibody formation, what you would find is that there would be presence of, finding number one, peripheral smear is going to be showing you presence of cells. Peripheral smear is going to be showing you presence of cells which are not having the presence of a central pallor. Peripheral smear having the presence of cells which are not having the presence of a central pallor. That is first fact that you need to remember over here. Second fact is that if you're going to be performing a test which is given the name of Coombs test, then Coombs test is going to be coming out to be positive in these patients. That can be an example of a direct or an indirect Coombs test, right? I repeat the fact that if you are talking about a patient who's going to be having a spherical RBC on the peripheral smear, then number one cause that you have to think over here is going to be immune hemolytic anemia, right? Having said that, we are going to be having a situation when the patients can be having the presence of cold autoimmune hemolytic anemia. Now, one example of this kind of a condition can be, we do not know the cause, but that can be idiopathic, or it can be associated with conditions like mycoplasma infection or infectious mononucleosis. In such a situation, what the patients can be having over here is that on exposure to cold temperature, this patient is going to be having agglutination of RBCs. So that's given the name of CAD, cold agglutinin disease. So classical history would be that this guy is going to be moving out in the winter weather without wearing proper gloves, or maybe, For some reason, he is not wearing it, or maybe perhaps unfortunately he is not affording it, and he is going to be having a sluggish circulation in the peripheral parts, digits, ear, and tip of the nose, and because of which he is going to be having the presence of agglutination of RBCs. So that is what is going to be responsible for causing acrocyanosis, bluish discoloration that could be present in his digits. That is very much suggestive of an individual who is going to be suffering from a condition like cold agglutinin disease. So A for agglutination, A for acrocyanosis, that's a finding. If we take the blood sample of these individuals and we look at the RBCs, RBCs in fact can be seen to be presence of agglutinated state. RBCs are present in a state of agglutination in case of a patient having cold agglutinin disease, particularly when you take the sample and put it on a chilled or a cold slide. Remember the fact, we can be having a special subtype of cold autoimmune hemolytic anemia in which the nature of the antibody is G, and that condition is going to be given the name of paroxysmal cold hemoglobinuria. Paroxysmal cold hemoglobinuria is an example of a condition that is going to be seen in case of children. Children having a history of viral infections, and then they are going to be having formation of an antibody that is given the name of Donath-Landsteiner antibody. Donath-Landsteiner antibody. This biophenotypic antibody is going to be responsible for causing intravascular hemolysis in the children. So child history of sore throat is present, and this child is going to be having passage of altered color of urine. So from the name you can get a hint that paroxysmal cold hemoglobinuria, paroxysmal episodes, or in case where the child is having a cold, exposed to cold as well, and this child is going to be having hemoglobinuria, passage of hemoglobin in the urine, so history of altered color of urine. Name of the antibody over here is Donath-Landsteiner antibody. So these are the two important subtypes of immune hemolytic anemia, the warm subtype and the cold subtype. So three important questions asked in the exam. It can be an image of spherical cells without central pallor. It can be an image which is going to be showing you acrocyanosis, cold agglutinin disease, or it can be an example of an image where actual agglutinated RBCs can be seen, clumping of the RBCs. I reiterate that if you have to differentiate between this condition and hereditary spherocytosis patients are not going to be having the presence of a positive Coombs test. Coombs test is negative over there. In this condition, Coombs test is going to be positive. That's what you need to remember so far as this condition is concerned. Having had a word about this, we can talk about a condition that is going to be given the name of aplastic anemia. Aplastic anemia actually is an example of a immune dysfunction in which there is formation of T cells against the hematopoietic stem cells. So even though the name is anemia, but as we discussed earlier, in this condition, the bone marrow cells are going to be replaced by fat cells, and therefore the patients are going to be having pancytopenia. Important thing to be remembered is that in case of aplastic anemia, we never ever get increase in the size of the spleen. Splenomegaly is characteristically absent. So if you suspect aplastic anemia and the question says splenomegaly is there, or clinically also you find spleen is enlarged, then your diagnosis is not correct. That's the point. When there is infiltration of the bone marrow by the fat tissue, the production of the RBCs is not taking place properly. If erythropoiesis is not taking place properly, what will happen to the reticulocyte? Reticulocyte count is going to be less, and that is why it is said reticulocytopenia is the rule. Aplastic anemia can be seen because of genetic conditions. It can be seen because of certain other causes as well. Say for example, a virus that is given the name of parvovirus infection. Now this parvovirus infection is going to be responsible for causing a transient kind of a decrease in the activity of erythropoiesis, but sometimes it can result in a prolonged suppression of erythropoiesis as well, in which case it can be associated with the development of a condition like aplastic anemia. Patients having aplastic anemia are having replacement of bone marrow by fibrous tissue. So if I try to aspirate something, I'll not get anything, and therefore I would be having the presence of a dry tap. So what should be done for confirmation of diagnosis? For confirmation of diagnosis, what you need to remember over here is we have to perform a bone marrow biopsy. What will the biopsy show you? The biopsy shows you empty areas in the bone marrow. Very shocking and that for the patient. Empty areas in the bone marrow because of replacement of the cellular tissue by the fat tissue. This condition is slightly different from another similar appearing condition which is asked in the exams, which is going to be given the name of pure red cell aplasia. Pure red cell aplasia is an example of a condition which is associated with selective problem of RBCs only. There is no problem with platelets. There is no problem with granulocytes. Selective problem of RBCs. Why would we have pure red cell aplasia? It is having a definitive association with a tumor that is given the name of thymoma. So that's what we need to remember over here. Then we're talking about conditions in which there is a physical damage which is going to be seen in the RBCs. Physical damage in the RBCs is going to be responsible for causing a traumatic injury to the RBCs, and that takes place within the blood vessels. So that's given the name of an angiopathic hemolytic anemia. Now, angiopathic hemolytic anemia, if there is a physical damage, that can be responsible for causing abnormal shape of the RBCs, fragmented RBCs, which are given the name of schistocytes or helmet cells. If we are talking and looking at small blood vessels are affected, then we are talking about the conditions like DIC, hemolytic uremic syndrome, and TTP. And if we are thinking in terms of involvement of the major circulation issues, say for example, then we are talking about the causes. Say for example, the patient has had recent cardiac valve surgery, especially in case of metallic valves. So metallic valves will cause a physical damage to the RBCs, and that can be responsible for causing angiopathic hemolytic anemia. So we are going to be having a common finding for micro and macro angiopathic hemolytic anemia, that is broken RBCs, fragmented RBCs, or schistocytes. Schistocytes are going to be having an appearance in which RBCs are going to be having this kind of a picture. Another cause that we need to remember over here is that out of the second cause apart from cardiac valve replacement, which can result in macro or big size angiopathic hemolytic anemia, is going to be something like a giant hemangioma. Another special condition that is worth making a reference of over here is a condition in which RBCs are going to become tear-shaped, and tear-shaped RBCs are given the name of dacryocytes. Dacryocytes can be seen in multiple conditions, but the commonest that we need to remember over here is a condition associated with fibrosis of the bone marrow. So that's termed as myelofibrosis. So whenever we are thinking in terms of RBCs which are going to be having a tear shape, that's what is going to be associated with the presence of myelofibrosis. Of course, it can be seen in other conditions. For example, patient is having thalassemia. It can be associated with myelodysplastic syndrome as well. It can be associated with iron deficiency anemia as well. Why? Because in all these other conditions, you're going to be having the presence of poikilocytosis, right? But the commonest is what you have to remember over here. That is going to be myelofibrosis. So that is what you need to remember so far as the discussion of the red blood cell disorders is concerned. We are now going to be having a discussion about the WBC disorders, and the way the questions in the exam are going to be framed is that they will be asking you questions pertaining to a specific type of a white blood cell. This can be given to you as a theory-based question, or they can be given to you as an example of an image-based question, wherein you are expected to identify the different types of white blood cells, be it a lymphocyte, a monocyte, a eosinophil, a neutrophil, or a basophil. Now, each of these cells is going to be specifically increased in conditions which have been mentioned in the table for you, and therefore that is what you just need to remember. More importantly, what you are going to be asked as question in the exam is going to be pertaining to the leukemic disorders, and that's a very basic background of the two types of the cells that we need to have an idea. One which is going to be given the name of a lymphoblast, the cell which is going to be having the presence of a condensed nucleus, and it is having the presence of an agranular cytoplasm. Lymphoblasts are going to be picked up with the help of stains which are going to be the TDT stain and the PAS stain. Of course, the number of lymphoblasts is going to be increased in case of a cancer that is going to be given the name of acute lymphoblastic leukemia. On the other hand, as I when making a mention of the myeloblasts, they are going to be having less condensed nucleus, so you can make out the presence of 3 to 4 nucleoli over there. And myeloblast is going to be having the presence of a granular cytoplasm, which we understand is going to be associated with certain types of terms. One which is going to be abnormal azurophilic granules, which are given the name of Eor rods, and you can be having multiple Eor rods present in case of a cell. So that's a time when it is going to be given the name of a faggot cell. What are the stains by which you see for the presence of a myeloblast? It is going to be picked up with the help of myeloperoxidase, the non-specific esterase, and Sudan plaque P. That is what we need to remember about these cells. Now, shifting our attention primarily to the different types of leukemias. Of course, if we are having the presence of a feature of the excessive growth of the cancerous cells, they are going to replace the normal cells of the marrow. So they are going to be associated with reduced numbers of the RBCs, WBCs, and platelets. And therefore, the patients are going to be having presence of fatigue. They can be having presence of anemia-like manifestations, bleeding tendency because like petechiae purpura, and the patients are going to be having the presence of fever. Along with that, quite commonly, leukemias would be having the presence of hepatosplenomegaly, and the patients can be having a development of sternal tenderness, particularly in case of acute leukemias. Short history is what is going to be an absolutely characteristic feature that is going to be given with respect to acute leukemias. And any kind of an acute leukemia where you have an increase in the number of lymphoblastic cells is what is going to be characterized by acute lymphoblastic leukemia. This may be associated with the presence of certain types of translocations like translocation 1221 or translocation 922 or translocation presence of mutations like the Notch mutation. We need to remember that why are we asked questions in the exam time and again with regards to acute lymphoblastic leukemia, simply because This happens to be the most common type of the cancer that is going to be seen in case of children. The investigation is going to be dependent upon demonstration of the premature cells or the lymphoblast, which has to be usually more than 20%. And whenever we're going to be talking about this kind of a cancer, the other high stuff to be remembered over here is the concept of the good and the bad prognostic factors. The good prognostic factors so far as this kind of a cancer include the patient who are going to be having an age anywhere between 1 to 10 years, less than 1 year, and more than 10 years, the prognosis happens to be bad. If you are talking about by race, white patients are going to be having a better prognosis. Females do better in comparison to males. When the tumor load is less, when the blast count is less than 1 lakh, that's the situation when it is better. Whenever there is going to be presence of a hyperploidy, and whenever you're going to be having the presence of trisomies 4, 7 and 10, that's what you need to remember over here. So trisomy 4, 7 and 10. And whenever there is going to be a presence of a situation wherein there is going to be presence of translocations like translocation 12, 21, or the patient is going to be having a B type of ALL. You see, if a patient is having ALL, he is going to be having increased number of lymphoblasts. Lymphoblast can be a precursor B cell or precursor T cell. So precursor B ALL is the one which is having a better prognosis. Females have better prognosis. Less blast count is having better prognosis. No testicular tissue, no bilateral involvement is having a better prognosis. Having the presence of trisomies 4, 7 and 10 has a better prognosis. Translocation 12, 21 has a better prognosis. On the other hand, males, black race, higher blast count, testicular involvement, T subtype of ALL, having the presence of notch mutation, having the presence of translocation 922, they are the ones which are going to be associated with poorer prognosis. Having an idea about that, we talk about the next example of an acute leukemia, which is going to be the acute myeloid leukemia. Now, this is an example again of a short duration cancer. It is going to be an acute leukemia, which is going to be having a mean age, which is going to be 60 plus years. When we talk about this kind of a cancer, we have the WHO classification wherein we are having 4 subtypes of AML. AML which are associated with specific genetic translocations. AML which is going to be having the presence of myelodysplasia like manifestation. AML which is secondary to a therapy, and AML which is not otherwise classified. Whenever we are talking about AML which is associated with specific genetic translocations, specific genetic defects, they are the ones that are more commonly asked in our exams. And the reason is that this particular type of AML for its diagnosis requires cytogenetic analysis, and it is not dependent upon any percentage of blast count. Whenever we are comparing this with the older FAB classification, we find majority of the FAB classification tumors would be fitting into something like the AML special genetic conditions. Examples would include M2 type of AML. M2 type of AML is going to be associated with translocation 821, and this is going to be associated with ocular involvement in the patients. That's given the name of chloroma. The most often asked example over here is that of M3ML, which is also being given the name of acute promyelocytic leukemia. Characteristically, these patients are going to be having translocation 15-17, because of which they are going to be having the formation of a promyelocytic leukemia and RARA fusion gene. The patients are going to be having quite an increase in the number of AOR rods, and they are at very high risk of development of disseminated intravascular coagulation. The only icing on the cake is that the undifferentiated cells in this kind of a cancer, they would be having an excellent response to the differentiation therapy which is being given with the help of a drug that is given the name of all-trans retinoic acid. As and when we are talking about too many AOR rods being present over here, that is what is going to be associated with the term faggot cells. Whenever we are talking about M5 AML, this is the one which is going to be associated with the presence of increased hyperplasia of the gingiva. So gingival hyperplasia, gum hypertrophy is a feature over here. And whenever we are talking about M7 subtype, the M7 subtype of AML, this type of AML which is given the name of acute megakaryocytic leukemia is associated more commonly in patients having trisomy 21, that's Down syndrome. And this one is going to be associated with fibrosis of the bone marrow as well. That means it is going to be having a presentation or having a finding on aspiration which is given the name of a dry tap. What exactly should be done to confirm a diagnosis in case of AML? So bone marrow examination to be followed by cytogenetic analysis. Cytogenetic analysis, and couple of terms that are always good to know: AOR rods, faggot cells, and Phi bodies. So for the one-liner questions, AOR rods, faggot cells, Phi bodies are findings that you associate in a patient who's going to be suffering from AML. In case of cancers which are going to be having a gradual duration of presentation, say for example, the patient is having the presentation of a cancer which is present over a period of many years, that is what is going to be given the name of a chronic malignancy. The moment we are talking about something like a chronic malignancy, the first one that we need to keep in mind is CLL. Why do we talk about CLL? Because it happens to be the commonest leukemia that we have in case of adults. This is classically going to be an example of a leukemia which is not associated with radiation exposure. But what has been shown is that whatever be the factors, that is going to be associated with development of deletion at the level of chromosome 13q. As I said earlier, these are elderly people who do not at times know that they are having a cancer, but they may be having presence of non-specific manifestations. They could be having fatigue, they could be having fever. At times, they may just come in for a general checkup in a hospital and they are found to have the presence of a lymph node enlargement. The origin of this kind of a cancer, very, very important, origin of this kind of a cancer is going to be taking place from a cell that is given the name of a naive B cell. For some reason, if that is not given as an option, then the other possibility from where the cancer can arise can be a post-germinal center B cell. Whenever we wish to make a diagnosis of this kind of a cancer, this cancer quite commonly associated with a high risk of development of an autoimmune hemolytic anemia as well. So whenever we are going to be looking at the peripheral smear of a patient who is going to be suffering from CLL, they might be showing us tumor cells which are going to be weak in strength and therefore they are going to get crushed. Such kind of tumor cells are going to be given the name of smudge cells. The trend in the current exams is the reverse is what they love to ask you as an exam. Elderly patient who has undergone a blood investigation. When you look at the peripheral smear, he was having smudge cells. What's the next thing to be done? Or what is the cancer that you may be suspecting? So if you're having presence of smudge cells over here, then you suspect a cancer like CLL. Tumor cells appear quite similar in case of patients having CLL. So they are going to be associated with the term convent girl appearance. Now, if you have the presence of smudge cells over here, you have to confirm the diagnosis. Diagnosis, incidentally, in this cancer is going to be confirmed with the help of an investigation that is given the name of flow cytometry. How would you or what would you look at in context of flow cytometry? In context of flow cytometry, what you're going to be having would be the presence of markers. And the markers by which you're going to be identifying this kind of a cancer is going to be CD5 and CD23. CD5 and CD23 are the markers by which we are able to pick up a patient who's going to be suffering from CLL. This is also an example of a cancer, please remember, which is to be differentiated from the cancer like a mantle cell lymphoma. So in case of mantle cell lymphoma, you are having CD5 positivity but 23 negativity. But over here in this kind of a cancer, what you are having over here is CD5 and CD23 positivity. So what I can add over here is that cyclin D1 is going to be less commonly expressed in case of this kind of a cancer. The other cancer that is asked in the exam is what is given the name of the chronic myeloid leukemia. This is characteristically associated with presence of a trouble in the patient which is in the form of a Philadelphia chromosome. Philadelphia chromosome is going to be an example of a reciprocal balance translocation affecting the long arm of chromosome 9 and chromosome 22. So this is going to be associated with presence of a fusion gene, that is the BCR-ABL fusion gene. This is going to be associated with formation of a protein that is going to be having a weight of 210 kilodaltons and that is going to be having a tyrosine kinase activity. As in case of CLL, a lot of these patients may be asymptomatic or the patients are going to be having the presence of a massive splenomegaly. This massive splenomegaly may be associated with compression of the stomach, so patient can have a complaint of a reduced appetite or they can even have a weight loss. Some of the patients can be having a development of increased TLC count which is going to be associated with the differentiation of this condition from a condition like leukemoid reaction. The differentiation, as I can understand over here, is leukemoid reaction is a benign reactive leukocytosis. Leukemoid reaction means TLC is increased after infection. But in case of CML, patients are having increase in TLC because of a cancer. Now, the characteristic feature that we have in case of CML would be that if you look at the differential count in these patients, they would be having the presence of not only leukocytosis, but they are going to be having the presence of basophils and eosinophils being increased. Patients are also going to be having on the bone marrow examination presence of cells which are given the name of sea blue histiocytes. They are also going to be having the presence of pseudo-Gaucher cells. If you look at their peripheral smear, the peripheral smear is going to be showing you presence of multiple types of precursors of the myeloid lineage. So you can be having band cells, you can be having myelocytes, you can be having metamyelocytes, and therefore the appearance of the peripheral smear is what is going to be associated with the term college girl appearance. So convent girl appearance or school girl appearance was a feature of CLL and college girl appearance is going to be a feature associated with CML. Other findings regarding CML is that these patients can be having increased levels of serum vitamin B12 and they can also be having another important finding which is going to be a reduction in their lab score. Decrease in the lab score can also be seen as a finding of a patient suffering from PNH. Why is that important? It is something which is not very specific and not very commonly done these days, but a differentiating factor in case of a patient who is having leukemoid reaction, which was a benign condition, lab scores are increased. CML is an example of a clonal myeloproliferative disorder. Lab scores are going to be reduced. That's what we need to remember over here. How would you confirm the diagnosis of a patient having CML? It's an example of a triphasic leukemia. So initially the patients are having a chronic phase lasting for many years. Then suddenly there is acquisition of more mutations. So chronic phase goes into the accelerated phase, and then the accelerated phase can actually cause death of the patient by progressing into the blast phase. So chronic, accelerated and blast, 3 phases are present, triphasic leukemia. The diagnosis is going to be confirmed. I mean, all the findings, massive splenomegaly, asymptomatic patient, elderly patient, having the presence of a decreased lab score, having the presence of the basophilia, eosinophilia, the confirmation of the diagnosis is to be done with the help of cytogenetic analysis. And amongst the cytogenetic analytic techniques, the most useful technique for this patient happens to be showing the translocation between chromosome 9 and chromosome 22. And that is what is going to be done with the help of an investigation that is given the name of fluorescent in situ hybridization. In some patients who are going to be administered the anti-cancer drugs, you might wish to show the presence of a minimal residual disease. So apart from the fluorescent in situ hybridization, another investigation which may be carried out in the patients in subsequent course of time happens to be something like the polymerase chain reaction. Medically, we need to remember that there is an example of an index which is going to be associated with CML, and that index is what you need to remember as the Sokal's index. So Hasford score and Sokal's index are terms that are associated with CML. How exactly is going to be the appearance in case of fish? So normally you would be having one gene, let us say ABL gene having a red color, BCR gene which is going to be having a green color, but patients having CML, they will be showing you the presence of a yellow color. That means the red and the green are coming together at a place. That is an indication of a fusion gene being present in the patients. That is what we need to remember over here. The other important thing that we need to remember is with respect to the cancers like hairy cell leukemia, another hot favorite of the examiner these days, it is going to be associated with the patients going to be having a trouble, that is presence of a BRAF mutation. As you might be able to recall from our discussion in the leukemia, that BRAF mutation is going to be seen in 100% of patients having hairy cell leukemia. It is also a condition in which the patients are going to be having the presence of massive splenomegaly, just like CML. But the difference is, in case of hairy cell leukemia, patients are going to be having pancytopenia. These patients are always at higher risk for suffering from infections. Say, for example, the infections that are going to be caused by atypical mycobacteria. This condition is special because unlike other conditions, in case of hairy cell leukemia, you get predominant involvement of red pulp of the spleen.